So that, let me give a small intro. Okay.
Yeah.
You can see the screen, eh?
Oh, yes.
Yes.
The website screen. Yeah. So welcome to all the faculty, and we are thankful to all the faculty and Dr. Sudhir Warrier for accepting the invitation of Gujarat Orthopedic Association. And today we are all masters of the scaphoid. So it is a master class. And if let me say that just starting before the webinar, 2849 people have already visited this page where to go at the time of starting.
Wow.
So that is a good thing. 2849 is the click just before the webinar. And for the delegates, here is the recordings. You can go to recording page. It is according to suggestion from one of the viewer. We have put the recording page here, previous webinars. And as you go down, you will find this webinar here. Just click this arrow, red arrow, and you will be there. And as you know, every day there is a Slido window where you can type your question and just click the button send. It will come to me and I will throw to the faculty and the moderator. Suppose you don't want to put a text, because I have made it to 160 characters only to get the precise, crisp questions only. So you can record the audio or video button here in the WhatsApp and just click this WhatsApp button to me. It will come to me. I will listen, and accordingly, if the question is not asked previously, I will pass on to Sudhir. So let me introduce the faculty in short. Dr. Sudhir Warrier, everybody knows him. Dr. Professor Joe Dias. Today, our web person has also put the links of the every author. So if they want to know anything about the author, they can come to their website also. Here you can see, just for the example, I have clicked the Dr. Joe's link. So same way, Professor Amit Gupta is from USA. Dr. Randy Bindra, everybody knows him because he is here in the previous webinars also. Dr. Chaitanya was also here in the previous webinar. Dr. Sumit Talwarkar is the head of the Rennington Hand Unit. Dr. Hemant Patnakar will join shortly. Dr. Ram Chidambaram from Chennai. Dr. Pankaj Ahire from Mumbai. Dr. Samir Kumta, plastic and reconstruction surgeon from the Mumbai. And Dr. Nikita Sethi, young orthopedic surgeon. And let me say that this activity, educational activity of Gujarat Orthopedic Association, for particularly this webinar, is supported by educational grant by these makers of Kalinta, Hyfec, Tarifrec of Intas company. Let me share one screen, because today I got a feedback that why not to have a yesterday, today and tomorrow page. So yesterday there was pediatrics. Today you are seeing the Scaphoid Masterclass, and at evening 5 p.m. again we are having the Masterclass of patellofemoral instability, where Professor Farkashan himself is joining from the USA, who has designed the osteotomy for patellofemoral instability. And tomorrow there will be total hip replacement and galaxy of the speakers, and day after tomorrow is the total knee replacement, and then after Dr. Javed Parvezi has agreed for periprosthetic infection. So he will be joining after 2 or 3 days. So thank you very much, all the delegates, for such an enthusiastic support from all corners. So Sudhir, I am stopping sharing. Now you can take the screen.
Thank you. Is that not happening? Yeah. Thank you, Navin Bhai. And it's really wonderful that so many of you have already joined this webinar. And let me tell you, I was naming it very simply by saying something, current concepts of scaphoid fractures and things like that. And he said, no, looking at the faculty that you assembled, and this is thanks to Randy Bindra's idea, the faculty is full of masters from all over the world. So he decided to give this term, and this is Navin's idea of saying demystifying scaphoid fractures, a masterclass. So he's already spoken to you about the faculty. Each one of them is a master in his own right, and it is an absolute privilege for Gujarat Orthopedic Association and for me to be hosting 4 editors of a forthcoming book on scaphoid fractures.
Sudhir, you are also a member of Gujarat Orthopedic Association.
Yes, I am. So there's a book that Amit Gupta thought up. Amit Gupta has written up 2 fabulous books. He's published his third book is getting ready, or is it out, Amit? So he's had the growing hand, the grasping hand. There's one coming out on anatomy, and he's planning the book on scaphoid. And Dr. Joe Dias, Amit Gupta, Randy Bindra, and Chai Mudgal are going to be editors. And I looked at the authors that are there in that book, and it's the who's who of scaphoid. Everyone that's published anything on the scaphoid is in that book, contributing in a very, very unique way. So this brings together these 4 absolute stalwarts of scaphoid fractures today. And for all of us, we must realize what sacrifices each one of them is doing. And this is how the world looks right now. This is the dark area that it's night. It's midnight for the Americans here in Boston and Louisville. It's early morning, 5:30 in United Kingdom, where Joe Dias and Sumit Talwalkar are. For us, we are in the happy position that the sun is not overhead yet. And for Randy Bindra, it's early evening. It's almost 2:30, 3 o'clock in the evening. So you can see we are stretching 15 hours across the globe, night or day, and that really doesn't matter. We'll go ahead with the scaphoid fixation, with the scaphoid fracture. Now, before we go ahead, I love this video and I love to show this to just give an idea. I'm sure many of us talk about the importance of the scaphoid, but just look at what the scaphoid is doing. Pay attention to this. And the link between the proximal and the distal row is the scaphoid. I just love this video because it puts into my head what exactly the scaphoid is. And if you now look at this and you just keep that sound in your brain of the train chugging on and think of the scaphoid, you'll realize that the link between the proximal and the distal row is that scaphoid, is that cam effect that the scaphoid is having. And it has to flex to allow and retain the relationship of all the other bones during flexion and extension, during radial deviation and ulnar deviation in particular. So having started that off, I would now like to stop sharing the screen and ask Professor Amit Gupta from Louisville, Kentucky, to speak about the anatomy, approaches, and the basis for the vascular grafts that we're going to see later in the day. The reason we're doing that a little earlier is because Amit and Chai Mudgal are working tomorrow morning, and it's 12:30 there, and we can't keep them awake till 2:30 in the morning. Thanks, Amit, and an absolute pleasure to invite you.
Thank you very much. Thanks, Sudhir. Thanks, Randy. Thanks, Navin bhai, for inviting me.
Thank you, sir.
So what we'll do is I'll go ahead and get started on this. So we'll talk about anatomy and vascularity of the scaphoid. Now, if you look at the anatomy, and this is from our dissections, which are going to be published in the new book, The Grasping Hand. So if you look at the 2 rows, as Sudhir was talking about, you have the scaphoid, lunate, and the triquetrum. On the distal part is the trapezium, trapezoid, capitate, and hamate. You see the midcarpal joint nicely opened up here. And on the volar side, you have an extra, the sesamoid, the pisiform bone there. Looking at the wrist from the dorsal side, when you retract the tendons, and this is the 3-4 portal. This is the 3rd compartment, that's EPL. This is the 4th compartment, that's the EDC. And between the 3rd and the 4th, you have the scapholunate interval right here. So this is the scaphoid, this is the lunate, and you see the scapholunate ligaments, the dorsal part, the interosseous part. And here you have the radio lunar triquetral or radiotriquetral ligament and the dorsal intercarpal ligaments there. Now, this is the scaphoid, this is the lunate here. Now, this ligament, the dorsal intercarpal ligament, can be of various shapes. And here you have it very thick. It's blended very nicely with the dorsal portion of the scapholunate ligament. And here you have the dorsal radiocarpal ligament, which goes from the radius in a variety of fashions. And there are 4 different types, and we can talk about this. Goes to the triquetrum there. So the triquetrum, all these ligaments are attaching to the triquetrum, and there is a interspace here, and you can take advantage of this interspace by, when you want to approach in a limited fashion. And Dick Berger has shown this, and you can make little windows in the capsule so you don't injure the important ligaments. And similarly, if you want to approach the ulnar side, you can make another window here. And again, you see a different modality or different structure of these ligaments. Another different structure of the dorsal intercarpal and dorsal radiocarpal ligaments. And again, here in a different perspective, you see the scaphoid here, lunate here, the scapholunate ligament. If you come to the palmar side, once you open the palmar side, from the palmar side itself, you don't see much. It's actually a very uniform type of a structure. And once you peel this layer off, then you can look at the individual ligaments. And then you have on the radial side, starting off, you have the radial collateral ligament. Then you have the radius scaphocapitate ligament, which goes across the scaphoid, waist of the scaphoid onto the capitate. And then you have the long radial lunate ligament, and you have the ligament of test 2, and then here you have the short radial lunate ligament. And beyond on the ulnar side, you have the ulnar carpal ligament. So you see the various structures which you see in the book, and I'll show you the structures here. So here you have the radial collateral ligament, the radius scaphocapitate, very thick ligament, the long radial lunate ligament, and the short radial lunate ligaments here. The relationship to the carpal tunnel, this is all the structures of the carpal tunnel removed. This is the flexor retinaculum or the transverse carpal ligament right here. And here proximally is the wrist joint. Here's the edge of the radius, and here's the ligaments of the wrist. Now, in looking at it again, you see the carpal tunnel here. This is the pisiform. This is the trapezium, and you have the radius here, ulna here, and you have the radius scaphocapitate, long radial lunate, and other ligaments here, which are fairly proximal to the carpal tunnel. And if you want to approach the scaphoid, you have to go through this and either divide them, or you can make a little Z-plasty like Mark Garcia Elias has shown. You can tease out these individual ligaments into different components, and you can identify them in different ways. And again, showing the different in different specimens. Now, if you look at it, you can see that there are spaces in between, and this is called the space of Poirier, through which dislocations can happen. This is a weak spot in the structure on the palmar side. These are the attachments on the of the radius scaphocapitate, long radial lunate, radius scapholunate, and short radial lunate ligament. The radius scapholunate ligament, or the ligament of test 2, is essentially not a ligament. It's a vascular channel through which blood vessels go to the lunate or to the proximal pole of the scaphoid. Now, looking at a different perspective, here's the scaphoid, looking at it from the lateral perspective. And here you have from the radius scaphocapitate. And you can see this. This is a very thick ligament across the waist on the palmar side of the scaphoid. And you can imagine that if you have a situation where the proximal pole of the scaphoid is trapped, and then you have a hyperextension force, this can break in the waist area, or even with the flexion force. Now, looking at the midcarpal joint, you see the scaphoid here, you see the lunate here, and on this palmar side, you have the radius scaphocapitate ligament, and on the dorsal side, you have the intercarpal ligament, dorsal intercarpal ligaments, and you can see how they form a nice groove into which the capitate and the hamate will sit. And again, a slightly oblique view. This is the scaphoid, and here on the palmar side, you have the thick radius scaphocapitate ligament. We've cut out some of the radial styloid, so you have the thick radius scaphocapitate ligament on the palmar side, and how it spans the waist of the scaphoid and going across into the capitate. all these ligaments you can see much better from the palmar, from inside the joint. So from inside the joint, you'll see this collateral ligament, radioscaphocapitate ligament, long radiolunate ligament, and this here, the frondy structure, you'll see that's called the radioscapholunate or the ligament of test 2. And this is your guide to the central portion of the wrist. Is leads your eye to the scapholunate ligament. So here is the scaphoid, here's the lunate, here's the scapholunate ligament, the intraosseous portion. This is the dorsal portion. If you go further volarly, you'll see the volar portion. So looking at it a little bit better, you see the wrist here. You have the scaphoid fossa, the lunate fossa, the scaphoid, the lunate, the ligament of test 2 right here, and the other radiocarpal ligaments right here. And you can see this on the scope. If you do a wrist arthroscopy radiocarpal, you'll see the radioscaphocapitate ligament here, and the long radiolunate ligament right next to radioscaphocapitate long radiolunate. And here's the long radiolunate ligament, or radiolunotriquetral ligament, as it's called. It used to be called before. Now here's the short radiolunate ligament. You don't really see this. It's covered very nicely from inside the joint. You have to do a fairly good dissection, but it's a thick ligament between the radius and the lunate. Here's the connection between the lunate and the scaphoid, the scapholunate ligament here, and this is going on to the. Now on the dorsal side, on the dorsal side, we saw the dorsal intercarpal ligaments. On the palmar side, you have very thick ligaments, which they can be dissected further. You can lift up the long radiolunate ligament, and if you lift up the radioscapholunate ligament, there is a deeper ligament called the scaphotriquetral ligament, which has not received much press in the literature. Now, if you look further into the scaphoid and the lunate, you'll see the scapholunate ligament. The dorsal portion is the important bit, the thick portion, and then you have the intraosseous part, and you have the volar portion. And the scaphoid and the lunate, they move in a corkscrew fashion, and you can see the movement here, the movement in a corkscrew type of a fashion. And again, here looking at it, the ligament of test 2 leading your eye onto the scapholunate ligament here. Now, if you look at the midcarpal joint, here you see on a standard arthroscopy, you should not be able to see big spaces here if the ligaments are intact, and you'll see all these volar ligaments we mentioned. And as far as the movement is concerned, if the distal pole goes into radial deviation, this will flex the scaphoid. It is a system of movement. It's called, in French, it's called the bascule. That means escape movement of the scaphoid. It has to flex. So in radial deviation of the wrist, the scaphoid flexes. In ulnar deviation of the wrist, on the other hand, the proximal row as well as the scaphoid will extend. So if you want a good view of the proximal row, you want to make an ulnarly deviated view. So let's skip through this. Now, in terms of the vascularity, you see that here's the radial artery coming across here, going through the snuff box. And as it goes through the snuff box, it gives branches to the scaphoid. Now, it gives branches to the scaphoid, to the waist, and to the distal pole. And you can see this very clearly here, waist and the distal pole. And you can see these branches quite nicely. And here's the scaphoid, and you'll see the branches going to the distal pole here, and the carpal arch branch going across like this at the snuff box. Now you see the carpal arch going across like this, and here branches to the scaphoid going through into the waist of the scaphoid. Here again, you see the scaphoid right here. This is the styloid of the radius, the radial artery coming across here and giving branches here. And here, nice branch to this distal pole of to the waist of the scaphoid, and one branch going to the distal pole of the scaphoid. Here again, branches going to the waist of the scaphoid, the distal pole of the scaphoid. Now, if you look at this one, this is from Gelberman's article, radial styloid, scaphoid, similar that we mentioned to the waist and to the distal pole, and again here to the waist of the scaphoid. Now, this is a beautiful photograph of the scaphoid. This is the radial artery going across. This is a superficial branch of the radial artery. The radial artery gives a branch to the waist of the scaphoid and one to the distal pole. And you can see, you can appreciate the proximal pole doesn't have much of a branch there. The intraosseous vessels, you have more branches to the distal pole, less branches to the proximal pole. Now, if you look at computerized imaging, you'll see the same thing, lots of branches to the waist, not branches to the distal pole, not many branches to the proximal pole. Approaches, you go volarly mostly. On the volar approach, you go the Roos approach, expose the FCR and retract it to one side and then go through the ligaments, or you can make a Z-plasty of the ligaments, as Mark Garcia-Lez has pointed out. On the dorsal side, you can go with a small incision in the 3-4 interspace, or you can make it a wider incision, retract the tendons, and then go across there. And this is just going with a dorsal percutaneous thing. Now, in terms of the anatomy of vascularized, you have the scaphoid fracture here with the proximal pole, and here the branches, which is described by Sheets and Bishop and Berger. This is the radial artery. Here are the branches to the radius. This is 1-2 ICSRA, intercompartmental supraretinacular, between the two compartments and over the retinaculum. This is again 1-2 ICSRA, first compartment, second compartment, and this is the 1-2 ICSRA. And this is this 2-3 ICSRA. This is the 4th ICSRA. Lots of vessels in this area, and you can take branches, you can take bone graft from these vessels and reflect them forward. This is 1-2 ICSRA. The first compartment tendons have been removed. And this is the dorsal intercarpal vessels, and these are the branches going on to the distal radius. And here again, you see the 2-3 ICSRA, and this is the 5th ICSRA. This is the 4th ICSRA, 4th EC, and this is the 5th EC, and these are coming together here to form the from the anterior interosseous artery. So you can take bone graft from here, and this will give you a long, very nice long pedicle. And this on the volar side, you can have these transverse vessels coming from the radial artery just distal to the pronator quadratus. And here you see the dissection. You can take bone graft from this area to the scaphoid very easily. So this is pronator quadratus taken out, and this is a vessel. You can take bone graft from here. So this, you took 1-2 ICSRA, taking a bone graft, putting it into the interspace, and you can see the bone graft is bleeding, and put the bone and put a nice small screw and fix it, and that goes on to heal. So this is another case in which the volar 1-2 ICSRA was fixed, and this is a volar vessel, the Matulin, and again we've shown this, and here you take it and put it in there to fix that. You can take, as I mentioned, take bone from the distal part here and put it in this interspace between the two. Recent article from Hill Hastings and Jeff Greenberg and Summercamp, and this shows nice fixation. So here's in brief, the summary of vascularity of the scaphoid as well as the anatomy of the scaphoid. I'd be happy to take questions. Thank you very much.
Navin, by any questions?
No, there is no question because it was so lucid and clear cut.
Yes, absolutely.
Yeah,
mind-boggling dissections.
Yeah, great specimens.
Fabulous visual impressions we are going to retain. Certainly, Frank Netter is going to have to take a back seat, unfortunately, Amit. We're waiting for the book. Well, it's really, really looking absolutely like a. I'm sure other parts of the body are begging for
Sudhir, one of the hand surgeon has now asked Dr. Anil Bhatt.
Yes.
Is there any ligamentous connection between capitate and lunate and its significance in perilunate dislocation and Mayfield's progression?
Well, there are capsular connections, and there are connections of the of these ligaments, which are the radioscaphocapitate or the long radiolunate ligament. There are always some connections coming from these ligaments, and if you dissect them very carefully, what we did was we dissected these specimens under the microscope, and you can see small connections going from the say the long radiolunotriquetral ligament onto the going from the radius to the lunate onto the triquetrum, And they may be small connections going off to the radioscaphocapitate ligaments from that sense. But there is no real direct connections as such. And of course, there are capsular connections.
Okay, his question was its significance in perilunate dislocation and Mayfield's progression.
Yeah, in perilunate dislocation, obviously we know that in perilunate dislocations, the weak spot that takes place on the volar side, which is the space of Poirier, the space between the two arcuate ligaments that we talked about, that space of Poirier is the weak spot, and the perilunate dislocations can happen through that spot.
I think, Dr. Anil, it satisfies your question. If not satisfied, you can ask again. Right, sir?
Yeah.
Sudhir, you can go ahead.
Thanks, Amit. We would love to have you for the 2 full hours or maybe more, but we won't stop you from switching off whenever you feel comfortable leaving us. It's been really wonderful.
Thank you.
I wish we could have you all through. Next, we would have Dr. Chaitanya Mudgal, who happened to do his residency with Samir Kumta around the same time at Sion Hospital, and currently heads the hand surgery in Howard at the Mass General Hospital. And he's going to talk to us about something very important, and that is so that we never ever miss a scaphoid fracture, which is the biggest bugbear of scaphoid fractures. He just sent me a message while Amit was speaking saying, please feel free to stop me if I go for too long. Chai, it can never be too long. You have to tell us everything that you know so that we can get that information and be very, very wary about looking at x-rays and the patients in our OPD so we don't miss scaphoid fractures at all. Chai Mudgal.
Share it, sir.
And Hemant has joined us right now.
Okay. Welcome, Dr. Hemant. And there is one question, Sudhir, but we'll take either, it will be taken care of. What is the direction of screw in the scaphoid? Should we go from proximal to distal? Just for the audience, it will be answered during the lectures.
Right.
But to have him a patience, I've just included.
So he'll hang on till he finds the answer, no problem.
Yeah.
You know, not to belittle anything, but I think before you start putting a screw, you want to diagnose the fracture first, huh?
Share your screen, Chai.
So you are speaking on diagnosis.
So, listen, it's almost 1 o'clock at night, and I'm going to be a little punchy. So, I'm making fun. The point is, we are going to try over the next few minutes to figure out A, how to make a clinical diagnosis, B, how to diagnose an acute fracture, C, if you can't see an acute fracture, then is it an occult fracture? Is it a no fracture? And then D and E are really, really critical because they determine the future of what happens to the scaphoid, i.e. diagnose displacement and diagnose instability, because both of these are controversial. So traditionally, we've been told that anatomic snuff box tenderness is the classic sign of a scaphoid fracture. Why is it that we go into the anatomic snuff box? Well, guess what? That's where the waist of the scaphoid is most palpable in ulnar deviation. And as we all know, the waist of the scaphoid is the most frequently fractured part of the scaphoid. So it makes sense for us to palpate in the snuff box. But what about the other areas? So you have the tubercle tenderness and the thumb compression test. And if none of these are tender, then obviously there is no fracture. But are these tests as good as we think they are? Well, let's look at the sensitivity in yellow and the specificity in blue. Anatomic snuff box tenderness and thumb compression have reasonable numbers for both sensitivity and specificity. But if you look at tubercle tenderness and pain on ulnar deviation, the specificity is all over the place. And this is based on 28 studies that's been published so far, which means that these tests are not as good for clinical diagnosis conclusively as we may want them to be. So in that being the case, Duckworth and his colleagues came up with a very nice suggestion, i.e., they said, let's see if we can predict the possibility of a fracture in someone who presents within 72 hours after their injury. So if it is a male under the age of 25 with anatomic snuff box tenderness on ulnar deviation and an injury which was sustained during sports, and they have tubercle tenderness, if they have all these four factors, then the risk of a fracture is 91%. However, the flip side was if the anatomic snuff box is non-tender on ulnar deviation, then they concluded that the risk of fracture is 0%. I mean, these are very strong numbers, but I would still say you take them with a little grain of salt because they're still guidelines. Okay, so you made the clinical diagnosis. Now what? Well, now you got to diagnose it radiographically. And traditional teaching is you got to get 4 views: the PA and lateral of the wrist, PA and ulnar deviation, and a pronation oblique 45. Now here's the kicker. If you have anatomic snuff box tenderness and you take these 4 views, up to 40% of fractures will not be seen on these 4 views, which is really concerning because everyone who walks into your office who falls off a skateboard or a scooter is not going to come into your office with such an obvious fracture. Not very uncommonly, you will see someone who comes into your office who falls off a moving treadmill. They're tender in the snuff box and the x-rays look like this. What are we going to do next? So traditional teaching was, if the snuff box is tender but the initial x-ray is negative, then you get a follow-up x-ray in 10 to 14 days because you're looking for localized demineralization, hoping that the fracture line will be much clearer. But that's traditional teaching. We are in 2020. If you look at the published data, it really does not support that traditional teaching at all, because this methodology has poor sensitivity, poor reliability, and a poor negative predictive value. So it's not the greatest way to go about doing this, which then means that we have to look at other imaging modalities, which I call adjuvant imaging. So the most commonly used methodologies are bone scan, CT scan, and MRI scan. All of these are relatively good when it comes to sensitivity, but realistically speaking, when it comes to specificity, MRI is a little bit better than the others. So I would say that MRI is best to either rule out or rule in a fracture. Now, what does the American College of Radiology say? Well, they decided that if you have a person come into you with a wrist injury and a snuff box that's tender, but x-rays that are negative, then to decide which methodology to image them by, they made them appropriateness criteria 1 through 9, with 9 being the most appropriate and 1 being the least appropriate. And they accorded an MRI criterion number 9, which means it is the best methodology to image the scaphoid when your radiographs are negative. Let me say that again. An MRI per ACR guidelines is the best methodology to image the scaphoid in the presence of ASP tenderness and negative radiographs. The CT scan is better than a technetium scan to rule in, whereas a technetium scan is better than a CT to rule out. But none of these come without any problems. With a CT scan or a bone scan, you have radiation. On a CT scan, vascular channels may give you an appearance of a false fracture. And then again, an MRI is expensive, and not all hospitals may have its availability. But then what are the advantages of doing it? Well, you get an early diagnosis and you save the patient from being tortured with a cast or a splint. And all of those come with their own complications. Now, we seem to think that splints and casts are relatively innocuous. But guess what? They're not. Complication rates from these can be as high as 7%. In addition, the patient is stuck out of work and loss of productivity. And the MRI gives you the possibility of diagnosing other pathology as well. Now, we live in a cost-conscious world. So if you were to compare casting with 2 sets of x-rays, 2 weeks apart, loss of productivity, and then take an x-ray that's negative and MRI directly, the cost is almost exactly identical. So cost is really not something we should be thinking about when it comes to this. But at the same time, if we are going to ask for sophisticated investigations, then I think we have to be darn sure of knowing what we're asking for and how do we interpret the data that's sent back to you and not rely on the report that comes to you. So for example, when you do a CT scan, Ring and colleagues pointed out that we need to do a CT scan along the long axis of the scaphoid. If you look on the top left radiograph, the scaphoid appears reasonably well lined up when you look at it in the scaphocapitate joint. But when you get a CT along the long axis, you see that the scaphoid is really translated and there's cortical overlap, thereby suggesting that this is really a displaced fracture. On the other hand, when you look at the bottom left picture, that scaphoid to me looked initially very displaced. until I got the CT. And the CT showed me that really my concerns were unfounded and the scaphoid was actually very lined up. So I utilize a CT to decide on the cortical breaks, to assess displacement, and most importantly, to assess comminution. I also use a CT to decide when the fracture is healed. When it comes to MRs, again, you have to look at T1 and T2 fat sat images, stir images, and then you're looking for something that may be entirely normal, like you see in this T2 weighted image, or you may have an obvious fracture with edema, as shown by the arrow. But then what do we do when you see edema, but no obvious fracture? Now that is debatable, and I won't go into that just yet. So going back to our lady who fell off the treadmill, here she is. These were the x-rays on day 2, and they were considered negative. Not surprisingly, the surgeon taking care of her then had x-rays done on day 14, and they were still inconclusive by their report, at which point she came to see me. And then she had an MR. And the MR was a dead giveaway with a fracture line and surrounding tremendous edema, clinching the diagnosis. Okay, so we made the diagnosis. Now the question is, what are we going to do with this? Why do we think that it's so critical to know if the fracture is displaced or not? We need to know if the fracture is displaced or not because the risk of displacement or the presence of displacement increases the risk of non-union by a factor of 2 for each 0.5 millimeter of translation. Let me repeat that. The risk of non-union is increased by a factor of 2 for each half millimeter of translation. Now let's think about this, okay? Half millimeter of translation, you cannot do that on a plain X-ray. You've got to do it on a CT scan because the assessment of displacement on a plain radiograph of 0.5 millimeters is challenging, if not entirely impossible. So then you have to look at a CT scan and you're assessing gap, translation, angulation, and rotation. But a CT scan by itself is in fact augmented when you add plain X-rays to it because the combination increases your sensitivity and a positive predictive value. So if you have a gap or a translation of more than 1 millimeter, an intrascaphoid angle of more than 35 degrees, I'm a little leery of measuring the intrascaphoid angle because it can be quite challenging. A lunate dorsal tilt on a true lateral radiograph of more than 15 degrees. And most important thing to me, which I find is what Nakamura showed us in very long ago, that the distal fragment can pronate in up to 36% patients, and you may not diagnose it, but that pronation of the distal fragment is what can give you cortical overlap in the true axial view. So let's go back. Is this fracture displaced? It doesn't look too bad on these plain radiographs. All the cortices seem to match. You get the CT, looks very promising, and then you get the lateral. And you can see the cortical overlap as well as the gapping dorsally. This cortical overlap is an outstanding example of the pronation that occurs to the distal fragment. So this was okay when we saw fractures that were displaced or semi-displaced and you got them on CT. But what do you do with a fracture that looks like this? How can you predict instability? And why are we so hung up on instability? Well, an unstable fracture portends displacement, and displacement portends lack of union. Therefore, we are always worried about instability. Now, if you look at the historical views, you have the horizontal oblique, the transverse, and the vertical oblique fractures, which Rusey gave us nearly 5 decades or 6 decades ago. And Tim Herbert came up with a more robust classification in which he gave us 2 sets of injuries, the stable acute and the unstable acute. The problem with this classification in today's day and age may be considered a little too simplistic. Why do I say that? Well, not too long ago, Bill Geisler and Joe Slade, the late Joe Slade, said that while it is reasonable to assume that displaced fractures are unstable, it is not as clear how many undisplaced fractures are unstable. And there we are left with this conundrum. What do we do with undisplaced fractures which may be unstable? We go back to CT scan and we use similar criteria as we outlined before. If you have a gap or translation of more than 1 millimeter, comminution or bone loss. And here's the important thing, other local fractures, i.e. the radius, lunate, triquetrum, anything. Proximal pole fractures, transscaphoid dislocations, again, lateral intrascaphoid angle of more than 35 degrees, because this increases the risk of non-union ×2 for each 0.5 millimeter of translation. But is it still as simple as we make it sound? Or is it as simple as Herbert made it sound? Herbert has been on record as saying any fracture that crosses both cortices is almost certainly unstable. Look at the choice of words. Almost certainly. That's hedging his bets, with all due respect. So then, is this fracture unstable? Well, it seems like it's going across both cortices, but in the CT scan, it seems unicortical. Well, look in this view, again, both cortices, and extends to the proximal pole. So this is a classic triplanar fracture of the scaphoid, which, because of the broad area of contact among various planes, was actually considered one of the more stable injuries and went on to heal uneventfully with about 8 weeks of casting. This, on the other hand, is someone who fell off a stage about 10 feet, has a displaced comminuted fracture of the distal radius, and a displaced comminuted fracture of the scaphoid. There is no way that you can consider this fracture to be stable. This is saying unstable to you loud and clear. And then you have something like this. You look at this fracture, it's in the proximal third, you could consider it a proximal pole. On the PA view, looks reasonable. On the oblique view, looks reasonable. Is there any reason that we should think of this as unstable? Well, think again, because that's what the CT scan shows you. So prediction of instability is still quite a conundrum as far as I'm concerned. So what are the take-home messages? If the anatomic snuff box is non-tender, fracture is unlikely. The concept of doing x-rays at 10 to 14 days is poor in terms of its predictability, its reliability, and its diagnosing capabilities. MRI, again, is the best for occult fractures or other injuries using ACR guidelines. CT is best for displacement, comminution, and assessing union. And finally, if someone can come up with a better method of prediction of instability, it'd be great, because the way it stands currently, it is extremely difficult to predict instability conclusively. Thank you.
Thanks, Rai. That was absolutely fantastic. If you stop sharing screen, I just...
meanwhile, can I ask a question? There is a question from, again, the masters are asking the masters. Today, I'm seeing that the general orthopedic surgeon is asking, because it's so lucid. So Parag Lad, hand surgeon from the Mumbai, is asking, Dr. Chaitanya, when do you advise adjuvant investigation like CT, MRI, if X-rays are normal and ASB tenderness is plus? Is it immediate or after 10 days or 2 weeks?
So if someone walks into my office and they fulfill the criteria which I outlined from Duckworth, a male under the age of 25, sporting injury, ASB tenderness and ulnar deviation, and tubercle tenderness with negative radiographs, I send them for an MR.
Okay. Now there is also a follow-up question to Dr. Gupta is there. Dr. Tahir Ansari, he has asked, is there any true ulnar collateral ligament of the wrist?
Well, you can, when you dissect these ligaments, as I mentioned, if you look at it from the volar side or from the radial ulnar side, you have a very uniform structures. And then it depends on your dissection techniques, and you can make any ligament and you can put your name in it. So it is possible to make out ligaments which may not, in fact, be true ligaments, maybe separate strands of collagen fibers, which you can tease out. But as far as the radial collateral ligament, that is a true collateral ligament. As far as the ulnar collateral ligament, they blend with all sorts of ulnar carpal ligaments, and you can really tease out fragments of collagen and make them ligaments, which may not be true.
Okay. Dr. Parag Lad has sent you the thanks, Dr. Mudgal. And Dr. R.M. Chandak is asking any role of dynamic MRI. He has written SRI, but probably it's a typing mistake. Any role of dynamic MRI?
I don't use it. I'm not sure I understand it, but at the same time, if you use the methodologies that I outlined and are looking at the sequences that we talked about, they give you more than adequate information, whether you want to rule in or rule out. With that kind of sensitivity and specificity, T1, T2 stir images are more than adequate to make a diagnosis.
Okay, again a question from Dr. Bintesh from the Guntur. How is the comparison between the contrast gadolinium and plain MRI?
I leave that up to the discretion of the radiologist, but by and large, if you do normal sequences, it's more than adequate for me. And gadolinium is not exactly a freebie. It does have its own issues. So.
Oh, okay, and there is an anonymous, it is not named. Is the CT scan predictor of the instability when it does not show the ligaments?
I think that's a good question, because you cannot look at predictors of instability as isolated bony without ligaments. But at the same time, we rely on the diagnosis of displacement and instability together. They mesh together. And when we talk about instability, we are largely relying on fracture patterns to predict instability, not so much so ligaments to predict instability. So.
Okay. Again, anonymous. Sir, if you are sending MRI, it will diagnose the fracture. But if you plan for operative treatment, do you again ask for the CT scan? So both are needed. That is the question.
See, here's the thing. If you're sending someone for an MR, it is because you can't see the fracture. And that takes an assumption that if you cannot see the fracture, it is highly unlikely that it's displaced. If it is not displaced, then why would you want to fix it? Because the success rates of treating it non-operatively are in excess of 95%, if not more. So the question of surgery doesn't arise. For me, the question of surgery arises when the fracture is either displaced or the patient is unwilling or unable to tolerate a cast. And most of my patients who are unwilling to tolerate casts are usually physicians. So,
yeah, Dr. Tanna sir has commented that is it that easy to get MRI by house medical officer HMO in ordinary patient? That is the situation probably in India. Dr. Tanna sir has commented like this.
I mean, you know, each healthcare system has its own pluses and minuses. In my healthcare system, we can order an MR and expect to have it within 2 days, and we can get a CT scan in 30 minutes or less.
And the next question is, how soon the MRI can be confirmatory 100% for the diagnosis? How soon? Any time frame? Yeah.
An MR which shows edema will show edema within 24 to 48 hours.
Okay. This question is asked by the Silas Gupta. Now he has revealed the name. Now, Dr. Abhijit Wagaonkar, again a hand surgeon. Question to Dr. Mudgal. What is the best radiological predictor of the union?
CT scan for me, every time. I use a CT scan, but the problem with the CT scan is you have to decide. We don't have good software that predicts the amount of trabecular growth across the fracture site. And most people would say that if you have 50% trabecular growth across the fracture site, the scaphoid is strong enough to consider it healed. But we conducted a study, which I've published, and we gave CT scans of my patients to a group of about 140 surgeons. And we had them assess the amount of trabecular growth and the location of trabecular growth. And guess what? The consensus was so poor that 2 radiologists and 2 surgeons cannot agree whether there's enough trabecular growth or not. So even though CT scan is a good indicator of union, it's not perfect.
Okay, now again, Dr. Anil Bhatt is asking to Chai, will you treat a complete waist fracture as unstable after CT shows no displacement?
If the CT does not show displacement, I don't consider. So that's where I said, Dr. Herbert's statement was a very powerful statement, but I don't think it's the holy grail in that sense. I think he that's why he used his words very carefully. He said almost certainly. And I think that's a very good choice of words. So no, I don't. I offer the patient the choice. And like I said, most of the time, patients who refuse to have casts are physicians, and they end up having surgery for fractures like that.
Okay, then now again the question from Dr. Bipin, should the undisplaced fracture do you consider the high demand patient to be operated, or is there in relation with the demand and misplaced fracture?
Navin, if I can interrupt here.
Okay, okay, sir.
This will form part of Joe Dias's talk.
Yes. Okay, fine. But there are two questions to Dr. Gupta, I think, before he leaves us. Dr. Parag Munshi is asked that Dr. Gupta, which vascular pedicle graft is most predictable in clinical practice in your experience in the non-unions regarding the anatomy?
You're muted, Amit.
You're muted.
Okay. It all depends on the position of the vessel, of the position of the non-union, and what you want out of your vascularized graft. If you're looking for a vascularized graft just to supply vascularity, especially to the proximal pole, my preference would be 1-2 ICSRA. If I'm going from the dorsal side for a slightly longer pedicle, then I will take a longer pedicle, as I mentioned. I'll take 2-3 based on the 5th EC so that I get a long pedicle. If I want a substantial amount of bone to reconstruct a humpback type deformity, then I'll choose a Mathulan graft from the volar side. Those are my choices.
Okay. Doctor, last question, Sudhir. Dr. Parag Lad has asked to Dr. Amit, what is the role of STT ligament in scaphoid fracture as anatomy is concerned?
There is, in terms of biomechanics, the STT ligaments are fairly substantial, and as we've seen in some of the dissected specimens, they can possibly form a way where the force is transmitted through the STT ligaments into either hyperextension or flexion, while the scaphoid waist is held or seesawing on the radioscaphocapitate ligament. So as the force comes down, the trapezium and the trapezoid are pushing transmitting the force onto the distal pole, and through the direct transmission as well as through the ligaments, they can flex or the distal pole while the proximal part is strapped. So it can form a mechanism of fracture, as has been shown by the biomechanical works of Weber and Chow.
Okay, thank you, Dr. Gupta and Dr. Chaitanya. Sudhir, you can go ahead, sir.
Just a couple of things. One is, I think Dr. Chandak probably mentioned about a dynamic MRI. He probably meant a dynamic contrast MRI. And I will remember Khushbu's contribution in the recently concluded Indo-US meeting, Indo-US hand meeting, which Chai Mudgal organizes every year. And Khushbu was talking about, from Picture This, she was talking about dynamic contrast being better than just giving gadolinium and taking late phase images, that the dynamic contrast gives you a better idea much earlier of the state of vascularity of the proximal as well as the distal fragments. That's one. Two is, I'd quickly I think a couple of things that I'd like to add to what Chai said. One is the fact that you need to sit like this, close to the patient. COVID times, be careful, but this is how you examine the wrist, not in any other form. You rest the elbow, keep the hand up like that, and then examine the wrist. The other thing is about palpation of the scaphoid for tenderness when the fracture is not running through the waist. While most of the fractures run through the waist, if you need to check, and if there isn't significant tenderness in the waist, then you need to check on the dorsum. The best guide to that is your Lister's tubercle that is marked here. And distal to the Lister's tubercle, when you just drop down onto the wrist in a little bit of flexion of the wrist, you are on the scapholunate ligament, dorsal scapholunate ligament, and everything radial to that, just distal to the edge of the radius, is the proximal pole of the scaphoid. So if you get tenderness there, there is a likelihood of a fracture of the proximal pole of the scaphoid, as opposed to if the tenderness was on the other side or along just at that point where it could be a scapholunate injury. And if you're looking for fractures of the tubercle, then the easiest way is to palpate the tubercle. And the best way to find that out is to palpate your PC form and run your thumb towards the radial side. And if you do that right now, you will be able to palpate the tuberosity of your scaphoid, which is nice to know where it is. And if you get tenderness there, that's where the fractures of the tubercle could give you tenderness rather than in the snuff box. It's also important because you know as when we come to the open treatment of these fractures or percutaneous fixation, then this is the bone that you want to palpate. That's just what I wanted to add. I'm going to stop sharing screen and I invite GOAwebinar. Anyone who opens PubMed or any such search engine and looks for anything to do with the scaphoid, you'll see papers just rolling out with J.J. Dias written on it. The guru of scaphoid, Joe Dias.
Thank you. I just need to be able to share my screen, I think.
Yeah.
Right. I've enjoyed those two presentations, absolutely masterly. I've been asked to cover just 3 aspects of acute scaphoid fractures. So I'm going to stick to brief. The first thing to say is that when you're looking at acute scaphoid fractures, there are 5 decisions that you take. Is the scaphoid broken, which Chai has addressed really well? Then how do you treat the acute scaphoid? And then how do you identify failure of that initial treatment? How do you treat when non-union treatment fails? And finally, what do you do to salvage the surgery? So the one that I'm going to address is this, the acute scaphoid fracture treatment. The second thing to say is that I'm just going to address the waist of the scaphoid, which accounts for about 3 out of 4 scaphoid fractures, because around 20% are of the tuberosity, all the rest are the waist, and it's only 5% at the proximal pole, which I'm not going to address in this lecture. So acute scaphoid fractures, and we've talked about imaging, and the common imaging for this is X-rays, and Chai has already mentioned the 4 views. The really important, the 2 important views that are not often used are the elongated scaphoid fracture, this one here, and this one will show you most part of the scaphoid. The good thing about the scaphoid is that it is splinted by the capitate on the one side and the distal radius on the other side. So it's held between these 2. So the only way it can displace is in the sagittal plane. So that is why you've seen the CT scans as well. The Chai has shown that it is the sagittal plane that will show you displacements. The second view is in fact the semi-supine or the 45-degree supine view, which is the one that tells you whether the scaphoid is above the ridge, which is the ones that usually tend to do quite well and you don't wind up with arthritis, and the scaphoid fractures that are below the ridge, which are the ones that you want to pay particular attention to. Once you've identified a bicortical fracture of the scaphoid waist, then the next thing to do is the decisions, and some of the questions were coming along this way, is should I fix, should I not fix, etc. The fixation itself is great fun. You can see that Sudhir has already mentioned the surface anatomy. The black line over here is the radial border of the flexor carpi radialis. And then this is your crease, which tells you the STT joint. Therefore, that is the tuberosity of the scaphoid. And between the middle wrist crease and the proximal wrist crease is the proximal pole. Therefore, what you do is you draw your line there, you put your Kirschner wire along that line, look at it on the imaging, and then you know whether you've got it right. Once you've got it right, small cut there, put in your Kirschner wire into the bone, and in 4 out of 5 times, it's quite straightforward to do. In 1 out of 5 times, it's not straightforward to do. It's not straightforward when the anatomy of the scaphoid changes. So either you've got a small pole or a very, very sloped STT joint, and those are the ones that will challenge you. So you just need to be aware of that. So that is fixation. So should scaphoid fractures be fixed? When we know that when you treat them in a plaster cast, that at least 9 out of 10 will join. And we also know that if you fix them, then around between 2 and 4% will still not join. So the difference between putting them in a cast versus putting a screw in it is quite tiny. We've heard some of the previous reasons given why you should fix, which are that surgeons prefer not to have cast on, and that is correct. That a very few occupations you can't do with a cast on, but in fact, in all the studies that we've done on scaphoids, and we've published on hundreds of scaphoids, surgeons are underrepresented in the population group. But that is a soft benefit. And finally, of course, if you operate, you're exposing patients to the risk of the surgery, both with regard to the implant, risk of infection, and the risks of anesthetic. And these are not inconsequential. What about casts? Now, one of the things that I was asked to do by Navin and Sudhir is to talk about the type of casts. And we published almost 30 years ago on just under 300 scaphoids that were either allocated to a scaphoid cast or to a cast with the thumb left free. And the disability from these two is completely different. If you put a scaphoid cast and you include the thumb and you move the thumb away from the palm, that hand is completely defunctioned. All you can do is a hook grip, and that person can't even look after themselves. You've severely disabled the patient. Whereas if you keep the thumb free or put the thumb so they can oppose it, then suddenly the person can function and function very well indeed, as I will show you. So there's no difference whether you immobilize the scaphoid, the thumb or not. So it makes sense to use the least defunctioning cast, and you use the cast without the thumb included. Now, we finished doing a huge study comparing early fixation of scaphoids to initial cast treatment, and I'll explain the two groups to you. This is the study that is funded by our NIHR. We've spent around £3 million doing the study across the whole of the UK. And the results are just about to be published in the Lancet. So we took 439 acute clear bicortical scaphoid fractures, not the questionables, not the impartials. And all of them had X-rays and CT scans before, and we randomized 219 to have surgery and 220 to have a cast put on initially. And if early it was identified that the fracture had not joined, you confirm that with a CT scan and you put in a screw. So you fixed any possible non-union quite early. Our main outcome measure was the patient-rated wrist evaluation, which has got two parts to it. One is pain and the second is function. And we looked at that right throughout the period up to 1 year, and we're doing the study now up to 5 years, and there was absolutely no difference. The union rate, 2 out of the 219 of the surgery ones did not join at 1 year, and 4 out of the 220, which were treated with an initial plaster cast, did not join. So the difference is very, very low. between the two. And it's really the numbers that you need to treat to avoid one non-union is 73. So 72 out of the 73 would have joined in any case. Return to work, and this was really interesting, that the difference between the two groups for return to work was only 1 day between treating initially in a cast, and in these days of COVID, you'll be quite confident to recommend a cast. But look at this, that complications, 1 in 6 had some complications after surgery, whereas 1 in 75 had complications after a cast. A huge difference. In fact, the only one that was permanently harmed is the one that had a screw put in, who's now wound up with a 4-corner fusion. So the recommendation based upon this study is that you should treat them in a plaster cast without the thumb. You identify at 6 weeks the state, and I'll come to that in a minute, and you fix the ones that have not joined. So in which ones would you consider surgery? And we've talked about the patient occupation group, like surgeons who need to have the hands free. If they're presented to you initially over a month down the line, then you're a bit uncertain whether this will go on and join, and proximal pole fractures of the proximal fifth. But in all these three, these are soft indications. These are our judgments for that particular patient. The one that it is not a soft indication for, as Chai has mentioned, is displaced over 2 millimeters. In our study, in the SWIFT study, we included all patients. 75 of our patients had displacement of between 1 and 2 millimeters. So that is the group. Now, when you look at displacement, we've already mentioned that these are CT scans, coronal images, and sagittal images. Here, there is no displacement. You can see this one is less than 1 millimeter displacement, slight gap, and the gap is more important than step. This is 1 to 2 millimeters. So all these three were included in the SWIFT study. So the SWIFT study results apply to that. The over 2 were excluded, but we did have a few. And you can see that the sagittal image starts showing you the gap at the back as the front of the scaphoid flexes down. But the rate, the numbers that account for this are very, very tiny. You're talking about 2 to 3% that will be over 2 millimeters, with the vast majority being either less than 1 millimeter and a small number being between 1 and 2 millimeters. So the final slide is, I was asked, what do you do early to decide? And we always make a firm decision at 6 weeks, 4 to 6 weeks. And what we do is we assess the patient out of a cast, and then we determine whether it looks as if the fracture is joined, where there are no concerns, and on just X-rays. At this stage, we do not do CTs for all patients. If we are concerned about union, then we get a CT scan immediately. And if there's a clear gap, then we recommend fixation. And then there's this group that you can identify the fracture, you're a little bit uncertain, there's some bridging, and those ones we review. And from the SWIFT study, we've not had a single person that we were concerned about because we could see the site of the union that then went on and had a non-union. So to summarize, acute scaphoid fractures, you'll be glad to know in these days of COVID, you can very confidently treat in a below elbow cast, but leave the thumb free, but identify a non-union early and fix it. Thank you.
Thank you, Joe. That was absolutely wonderful. I remember over 20 years ago, we did the hand meeting with Dr. Tarapurwala, when Randy was there and you were there. And I think we then just had the non-cannulated scaphoid screws at that time, the Herbert screw, I think, yes, it was the Zimmer, the Herbert screw. It was a big screw, and we had done a workshop, if you remember, Joe. And during the workshop, there's a jig that we used to use. It was called the Hewn jig. And Joe was so unhappy trying to fix the hewn jig onto the bone that he whispered. He had the mic on his collar, and or I was holding the mic. I don't think we had collar mics then. And I was holding the mic next to him, and he whispered into my ear saying, Sudhir, this jig is broken. And I had been using that jig for almost 2 years from the company, not knowing that it was a broken jig. I thought that was how it was meant to be. That was how poor our knowledge of what we were doing then was. But since then, we've come a long way, and Joe is now telling us we don't need to rush in as frequently as we do. I'm sure, Navin, there must be a lot of questions.
Just a minute, just a minute. There is a question from Dr. Dias, Professor Dias. In your SWIFT trial, what are the reasons for surgery group patients 31 crossing over to cast? This question is again from Dr. Anil Bhatt.
Anil, hi, thanks for that question. That's absolutely right. There were crossovers on both sides, less in the cast group than in the fixation group. The really interesting thing, it is a slightly unnatural thing to say, because what you don't know is whether the people that crossed over were the ones that were undisplaced, because all those 31 went on and joined.
Okay. So now Dr. Chai is not there, but still there is a question from Dr. P.M. Vekaria. How you judge a 2 mm gap? Oh, Chai is here. Okay.
Yeah. So
how you judge 2 mm gap?
So if the question is to me, then what you do is you measure it. But although it sounds easy to say you measure it, if you're measuring it on X-rays and you take the maximum displacement as the one to take into account, on CT it becomes really difficult, because you do not know which slice you should be measuring, and whether you're looking at the maximum gap between the two planes of the scaphoid or not. So for the SWIFT, what we did was three independent people reviewed all the imaging, and we used the middle third of the scaphoid, so the maximum displacement of the middle third of the scaphoid on the coronal view and on the sagittal view, and the maximum displacement was measured. So that is the way, but it's certainly not completely straightforward.
Okay.
I think the other point also that Joe makes is you don't want to rely on just a number in isolation. You have to take the displacement. If you measure it, you have to combine it with pronation of the distal fragment and look for cortical overlap. You just can't take one number and say, oh my goodness, it's 2 millimeters, let's fix it. You have to combine it with the other. So it's a little nuanced understanding, I think.
Okay. Again, is someone, your friend Chai, he has asked Dr. Terence, ultrasound diffusion, do you have 90% specificities and 50% sensitivities in diagnosing a fracture? Do you have any experience, and what is your take on it?
I have no experience with ultrasound, sorry.
I think the comment that I would make about ultrasound is you're going back to an observation made by McLaughlin and Parks in he published the good paper in 1969, but he first made the observations in 1954. And that is, if you had an effusion there, then the fracture was likely to be unstable. So it's very rare. All the classifications do not, in fact, take the most important factor into account, which is displacement. There are only two classifications, which is McLaughlin and Parks, and the Mayo classification, Bill Cooney's classification from 1980, that takes the displacement into account. None of the others, Schoenberg's or Tim Herbert's or Herman Kremer's, none of these take displacement into account, yet that is the single factor that we use to decide whether to fix or not.
Okay, Dr. Ayas, there is a question from Dr. R.M. Chandak again. On what points do we reassure the patient that this will heal, and whom do we increase the length of the cast beyond 8 weeks? You said the cutoff is 6 to 8 weeks, then you go for a fixation. Can we extend the 1 or 2 weeks and reassure the patient? That is the question.
So as I said, there are three groups. If you are concerned about union at 4 to 6 weeks, then you get a CT scan and confirm it. If it is not confirmed, then all you need to do is take them out of a cast, give them a splint, a removable splint for heavy use, and then they're allowed to use it. So we don't keep anyone in a cast for longer than 4 to 6 weeks. There's really no need to do that.
Okay, now there is a question from Nandan from the Hyderabad for the SWIFT study. Most of the fractures were treated by percutaneous or open approach. Whether there was any difference in the union rates in open or closed ones?
So we didn't analyze it that way, although we did have some that were open, some that were done dorsally, and most were done percutaneous Palmer. About 4 out of 5 were done percutaneous Palmer. But we've not analyzed it that way. If you start doing sub-analysis like that, then the data does not have the power for you to be confident of the answers.
Okay. Again, the question about the SWIFT study. Did the SWIFT study exclude the waist fractures, where all fractures were evaluated for late onset AVN?
So the only ones that were excluded were the proximal pole, the proximal 20% were excluded. All the rest were included. So that's the first thing. The second is we did evaluate for vascularity based upon radio density on X-rays or radio density on CT. There was no difference between groups, but the rate of AVN identified at 1 year was very, very small.
Okay, again the question from Dr. Tahir Ansari. A small group of the patients who are hyperlax and the smokers, should we include the thumb in these patients or not? Is there any difference with these variables?
That's a fantastic question, because Chai's talk about instability is related to laxity, and that is particularly true in the Asian subpopulation. So if you've got somebody who is hugely hyperlax, you're talking about a Baton score of over 7. So you're talking about disorders of collagen. Then those are the ones that we do, absolutely right, we do immobilize the thumb, because those are the ones that even when you pinch in a cast, you'll get quite a lot of movement because of the laxity of ligaments. But that is based upon an observation and thinking rather than on any data. Because when we specifically assessed laxity in the whole of SWIFT, and the laxity to have hyperlax people was very unusual in this group.
Again, an observation or a question from Dr. Bharat Kadadi from the Bangalore hand surgeon. Many times this sentence is said that when you see the scaphoid fracture on X-ray, it is obviously displaced. Is it true or false?
That is completely false, because when you look at the data, it is saying, what you need to be saying is, what do you mean by displacement? If displacement is any change from normal, then yes, all are displaced. But the displacement, the term displacement that we use in clinical practice is if it is going to heal in that displaced position, is it going to cause a functional problem? And for the scaphoid, that is very rare.
Okay, again, a question to you, Dr. S, from Dr. Bipin. In athlete, would you cast for or fix it less than 1 mm gap? The subset of athletes.
So the same thing. It depends upon what the sport is. Leicester won the Premier League in football a couple of years ago. Jamie Vardy had a scaphoid fracture. which he very happily treated in a cast, and he played and we won the league. So some sports you can play, other sports that are very risky, you are not going to be able to play. So that goes back to what Chaya said. There are few occupations that you can't do with immobilization, but most occupations you can do. And that is why the difference between our two groups was only 1 day.
Okay, sir. Dr. Anil has again asked you, Professor Dias, can you briefly explain your approach to acute proximal pole fractures? Will you be casting them in any scenario?
So I'm giving another talk, Anil, a little bit later.
Okay, fine.
I would be asking Sudhir whether it's possible to do it earlier, because I've got to go and do a ward round shortly.
Okay.
So,
Another question from Nandan from Hyderabad, again hand surgeon. Did you manage to be closed in the displaced fracture? In the displaced fracture, can you able to do a closed one, close management?
So up to 2 millimeters, there is no difference between groups. And we are not even seeing huge malunion in these. It's the one that are over that you start worrying about malunion or increased non-union.
Whether only IP joints should be left free, or both IP and MCP should be free in the cast, or only IP?
So we leave the whole thumb free, so the thumb can do that. So because that allows maximum function, and the movement of the scaphoid occurs during movement. Most of 80% of the movement of the scaphoid occurs due to movement of the wrist. So if you immobilize the wrist but keep the thumb free, you keep lots of the function of the hand, but still prevent excess movement of the scaphoid.
Okay, Harvinder Singh from the Punjab has asked, does the partial union exist?
Yes, absolutely. I didn't talk about union, but we've done a lot of work on this, of all these, and we've done exactly what Chaya said. All of them have had CT scans before and after. Most of them will have almost full or full union. There's about 10% that will have partial union, and most of these are over 50%, but there are a small number that are below 50%. So around 6-7% are below 50%. And those are the ones that we are watching. We are doing our 5-year review also with all CT scans, and we're trying to see whether that bridge of union increases and what is the rate of it going the wrong way and becoming a non-union. So we will be able to answer that question in about another year or two.
Okay, Dr. Tahir is, okay, Chai, go ahead.
I don't know if Joe agrees with this or not, but over the years, the one thing I learned was don't get the CT scan too early. You want to wait at least 14 to 16 weeks from the day of injury. You get it too early and it gets reported as showing less than partial union. And now you're left in a quandary what to do next. So I usually wait about 14 weeks before I get a CT. Do you do that, Joe?
So we just resolve, we use the CT not to define union.
Oh, you don't?
We use the CT to define a non-union.
I see.
So if you're concerned, so that is why we do it quite early. And the rest, we just do it at 1 year, because then you've sort of established for the ones that you were a bit uncertain about whether it is consolidated.
Dr. Dias, Dr. Tahir has again reframed, probably is not satisfied with the question. Do you take the smoking as an independent risk factor, whether the management strategy changes with the smokers?
Dr. Tahir, absolutely right. My apologies for not addressing that. We know in non-union that smoking between smokers and non-smokers, the difference, the odds ratio is 4.4, and this is Peter Burgess' paper. So we know that there's an impact of smoking if you are treating a non-union. We expect the same to be there in acute scaphoid fractures. In our study, we did show a very small effect of comparing smokers to non-smokers. So we adjusted for that. From a clinical point of view, absolutely right. In smokers, you would be a lot more cautious because they're cutting off their blood supply each time they have a cigarette. So you have to take note of Peter Burgess. So we do address that, and we are a little bit more cautious in that group.
Okay, Dr. Pradeep Kothadia from Solapur is asked, Dr. Joe. Last question. Yeah. Probably it may be covered in the talk, but we have to mention whether every non-union needs the treatment.
We'll be speaking about non-union.
Oh, yeah, that's why. But I'm mentioning just because they remain tuned.
I know what pressures you are under, Navin. Thanks a lot.
Thank you.
There's just a couple of things. We will have to disrupt the order in which we had planned the whole thing. It was meant to slowly unfold, and unfortunately, we will have to respect the fact that Joe and Sumed, for them now it's about 7 o'clock, and their duties are going to call. So we're going to just shift tracks a little bit. Before that, I should say almost all the questions that are coming in are from hand surgeons who should have been on the faculty here. Tahir is the chief of hand surgery at the All India Institute in Delhi, and he's been asking the most fabulous questions. I'm going to ask Sumed to speak next because he has a Zoom meeting with his board of directors almost immediately. So Sumed is going to talk about something that, yes, Chai?
I'm going to say good night.
Okay, good night. Thank you very much. Thank you very much.
Thank you very much, guys.
Good
Thank
night.
you.
To see you.
Bye.
See you.
See you
Bye-bye.
later.
Yeah, Sumed, I must show off this. No, those who can see this, that's where Sumed comes from Wrightington, the hip place. And I spent some time with Sumed, and he was kind enough to give me this, and I wear this, and I boast about this little lapel pin. Sumed's currently the divisional chief there, and he's also the grandson of A.K. Talwalkar and the son of C.A. Talwalkar, sir. Sumed is going to speak about something that most of us probably will never do in our lives. We are so scared of doing this, but he's been publishing on this, and he has his reasons, plating the scaphoid.
Thanks for inviting me, Sudhir and Navin. It's always an honor to speak to the Indian audience. So I'm going to speak on something slightly controversial. It's about scaphoid plating, and why do we even need it? Really, these are my conflicts of interest. So there's a reason why I'm putting this up, because I'm going to be speaking about the Medartis plate. But this is hopefully a balanced talk. I'll try and present our limited experience with this device. So do we really need a plate is the question, and I think that's a reasonable question to ask. We have casts, we have so many headless screws. The market is rife with all these different implants. And is there really a place for anything further? Because we know that the fracture will heal with a plaster or screws or even K-wires, as Dr. Batankar is going to talk to us later on about. And you'd be surprised to know that these plates have been around for some time. And in the 80s and 90s, there was a plate called as the Enders plate. And what it essentially did was that it prevented the escape of the bone graft from the fracture site. And I think they published a single paper in somewhere in 1992, I think it was in the European British Journal. But after Herbert's screw came out in 1984, because the ease with which you could put the Herbert screw in, even the non-cannulated version, I think the plating as a whole fell into a degree of disrepute. So if you look at the literature now, there are lots of case reports. There's one particular retrospective trial where they've published 32 fractures which have been treated by scaphoid plating, and they've been addressed in situations where there have been non-unions and also in acute fractures. Now, as far as Wrightington is concerned, my experiences with these type of scenarios, where you've got a bit of internal fixation in with cavitation, and you begin to wonder what's going on there with that distal pole, and we're going to struggle to fix that. Or if you have a non-union with a huge cavity like this, or one of my colleagues has done a few humpbacks where we put a plate down the front to correct the humpback deformity. The enthusiasts who have published, Greg Bain and company, they've done these in fractures which have a complicated anatomy. You know, when you have these steep oblique fractures or comminuted fractures, they put dorsal plates as well. So when you look at the biomechanics of a single screw, we know that by definition, it will only offer very limited stability, and it's poor in rotation. And this depends whether you have a type 1 or a type 2 scaphoid. And you know, this is work done by Fogg and his colleagues from Australia. You could use 2 screws, but that can be challenging. You know, if you have a very narrow waist, this can be an issue. That's really where the plate comes in, that in theory, it can resist rotational displacement to a greater degree than you could with a single screw fixation. There's no question that if you were to use 2 properly placed screws or even a screw and a stout K-wire, you could make up for the issues with rotation. So these are the theoretical biomechanical advantages that a Volar plate would offer. So coming back to our plate, the plate which is marketed by Medartis, it's been around for some time now. It's made of titanium. It has 140 degrees tilt. It's connected with these 2 little metal bars, and you have 3 screws, one for the distal pole and one for the proximal pole. And one of the big advantages here is that when you screw this on, the 2 metal bars keep your graft in place. So it acts like a buttress. It doesn't really work as well, in my opinion, as any form of compression plate. And this is how it would lie on the scaphoid along the volar surface. So Greg Bain has published a paper, I think it was about 4 or 5 years ago, where he's applied a similar plate, but to the dorsum of the scaphoid. Now, I personally have no experience with this at all. Most of our experience, or nearly all our experience, is with the Volar plate. So let's go to this very quickly. The approach that we use is the Garcia-Elias's approach. Volar across the FCR with the hockey stick extension. This is the exploration, as we can see. I tend to release the FCR quite distally in order to ensure that I can retract the FCR adequately on the ulnar side. Amit showed us the anatomy beautifully, the radioscaphocapitate and the radioscaphoid ligaments. So this is theoretically, again, a ligament sparing procedure. So just to outline the 2 V-shaped flaps, you take these, which are centered over the radioscaphocapitate ligament. Very often, these ligaments are not this clearly visible. You can see the appearance of the proximal pole, the distal pole, and the gap. This is what the fracture would look like once it's fully exposed. So what becomes very clear immediately, I think, to all of you is that the exposure is very, very important in these cases. Because if you don't have adequate exposure, if you can't see the proximal pole, you can come unstuck very, very quickly. And the reason for that is to do with the impingement of the proximal part of the plate with the distal radius. So as you can see here, very clearly, that's the distal radius, and this is how the plate sits. So this particular case had a happy ending. We had a fracture which was towards the waist, a little bit distal. Once we were able to jack it out, we were able to get 3 good screws proximally and 3 good screws laterally. And that's what I would probably call a sort of a textbook situation. Doesn't always happen. This is the appearance of the fracture. And this particular injury healed within 4 months. This was the other case which I showed you with a large cavitary defect, which we fixed with a plate. Again, plenty of real estate proximally, and that really is something that I look for when you use plating, because one of the problems that I've had, and I show you in a later case, is with impingement. You can mold the plate in a particular way, remember, because it's possible to then place it and contour it in such a way that the screws then move in this particular direction, and you just prevent that little bit of impingement which can occur. This is a case that I've done a couple of weeks ago, and you can see how easily you can get unstuck. In this particular case, I had to cut the proximal aspect of the plate because of repeated impingement. So we packed it up full of graft, stuck the plate in. One of the issues that I had was that the distal pole appeared to be splintering after we took the screw out. But unfortunately, because of the contour and the nature of the fracture, I wasn't able to place the plate distally enough. So as a result of that, I had to cut it, and you effectively end up with just one screw proximally, which in my opinion is, not great at all in terms of fixation. But, God is great. We managed to get this to heal. But this is something that we do sometimes where you have to contour it so it doesn't completely sit on the fracture, and you have to bend the plate in a way so that the screws can then move across. But this is a very important aspect, and very much on the learning side. I still believe, from my point of view, as far as my practice is concerned, with the average non-union, the average fracture that needs fixing, I would still use the headless compression screw as my method of choice. We'll publish our results when we do our first 50. We're looking at them prospectively. But there, we must have an open mind that there will be situations where an anatomical locking plate might be useful. And this would depend on the anatomy of the fracture, as well as the anatomy of the non-union and the presence or absence of huge bone defects. Thanks very much. Thank you.
Sudhir, unmute yourself.
Yeah, Navin, any questions?
There is only one question for the plate.
Mm-hmm.
Yeah.
If the plate does not compress, how is it supposed to treat non-union in scaphoid? It's a buttress.
Yeah, so I mean, I don't know what the rest of the panel think. When you have a situation where you effectively are taking down a significant chunk of bone away, so you have a non-union where there's a problem with the biology, you are trying to work on the biology, or you're trying to work on the vascularity to achieve union. So similar to how a K-wire works, or when you do large vascularized grafts, you have to fix the vascularized graft with the fixation, which can be only best described as tenuous. The plate works in a similar fashion. It works as a buttress. Biomechanically, all it does is it helps to hold the fracture volally. I frankly don't believe in some of the lab work that has been done, where they have shown that it can actually help in providing compression across the fracture site. I think that is too optimistic. So I think it just serves a buttress function, and there's no going away from the fact that your preparation, like for all hand surgery, the preparation of your non-union and the quality of your graft is very important.
Okay. Before the next question, let me have an announcement. We started with 2849, then it was 4752, then 6285, and now it is highest at the peak at 6578. Thank you. Thank you all faculties for a great contribution. And now the next question again for Sumit is, most of the time, these fracture non-unions are rotationally unstable. How do you stabilize them before you apply the plate?
So that's a very good question. So the order of, I apologize, I should have said this first. So I stick a K-wire down the non-union. I ensure that the K-wire has passed through both the poles and through the graft. You can virtually do this under vision, if you use an adequately shaped graft. And then what you essentially do is to ensure that you fix your distal part first, so that you make sure you're not sort of impinging, and then rearrange or position the plate over that proximal fixation. And the single K-wire very often is more than enough for sorting out the rotational bit. The other thing that you do is to use this bolster, which we use, which I'm sure all of you use. You use a large bolster, and you dorsiflex the wrist. So the minute you do that, you straighten up the scaphoid and effectively lock it in position. I find that quite useful.
Oh, so it's a controversial. So many questions are coming, pouring like anything. Was your decision to do plating is pre-op decision, or it's an intra-op decision? Anytime you change with the other matter and intra-op, you decided to go for plating?
So we've got a thing called Montgomery now in the UK, where essentially everything and absolutely everything, things that have taken me absolutely years to understand, I have to explain to my patient in a period of 30 minutes. So we have to go over the whole plethora, the whole range of options. So if I'm going to take a scaphoid out, a screw out and fix it with the help of any other device, it has to be made clear to the patient preoperatively that I might be using a plate. So that preoperative planning is done before surgery. So we sort of go in with preconceived notions that, look, it's likely that when I take this screw out, we are going to end up with problems. I might come unstuck and I might have to use a plate. You also make it clear to your patient that, look, I've done lots and lots of screws, but I've only done 10 plates. So you have to tell them that in no uncertain words, that, look, I'm on my learning curve and it may not work, but this, in my opinion, on the day is probably the best thing that I can do for you.
Okay, partly Anil's question is answered, but here ask about the brief about the complications, bailout options if this fails, and plate removal indications.
So very good question again. So if you end up with impingement proximally, you have to take the plate out sooner rather than later, because you're going to take a chunk of the volar part of the radius. So that's dangerous. Bailout options for, I've grown up I'm old enough to be able to use K-wires properly. So if it doesn't work, stick the graft in, put in a couple of K-wires and come out. Cut the wires in so that's always there for you. What was the third question? Was there
plate removal indication? Plate removal indication.
So I've had to take only one plate out where you had volar impingement, and it's likely that this other chap that I've just done, I might have to take his plate out, because if you have only one screw proximally, that one screw is it's just optimistic, isn't it, to consider that once I get this chap moving, whether or not he's going to do well. But he's one of those chaps who is not usually asymptomatic preoperatively, and that's probably another question which we are going to answer later on, of what to do with the asymptomatic non-union.
Okay. Then again, about plate removal, 2 or 3 questions, similar questions. How often you require plate removal? Does the plate produces the AVN? And what are the chances of impingement? The similar questions are there. So
sure.
It can be answered in one.
So impingement, we've had 2 cases, one previously where the impingement set seemed to somehow develop over a period of time after union. I can't explain why that happened when we've taken it out. It's likely this other chap had impingement during surgery, but we were able to obviate it by cutting the plate. I haven't seen any cases of AVN occurring. So far, the only reason for removal of plate has been for impingement purposes, but our experience isn't huge. So as a unit, we've probably done only about 15 over the last 3 years. So we are still gathering experience on this. So I wouldn't say I'm not an expert. I tend not to use that word in sentences.
Dr. Bindesh from the Guntur is asking about applying on the tensile surface. How is your experience?
So you mean on the dorsal surface?
Yeah,
I haven't done any. I would strongly recommend.
You already said.
Yeah. So I would say, one of the things about this is Greg Bain's paper is very interesting. If you look at, he's published it in Techniques of Hand Surgery. I might be able to bring it up if it's still up here. It's really worth reading. So I think if you can see here, this is his paper, Dorsal Plating of Unstable Scaphoid Fractures by Greg Bain and Joydeep Fadnis. Joydeep worked with us. So please have a look at this paper. I don't know whether I'm clever enough to put this plate over the dorsum of the scaphoid personally. It's hard enough doing it over the volar surface. But he's published this. But again, I don't think we've come up with any significant numbers of cases yet. So till then, I think I would be cautious. Okay, I wouldn't start off by plating scaphoids. I think putting screws in is probably a good starting point.
Okay, the question is again 2 similar questions.
Navin, Ram wanted to ask something. He's
okay.
It's a question like it's good choice for a non-union with a humpback deformity with bone loss. They had to put a graft and we make reasonable enough to support polar-wise. But for fracture, oblique fracture, would you still go for headless screw as your first choice? And then if it's not possible only, you will do this?
Absolutely. I completely agree. I'm better at the screw in those situations. There are some fracture configurations where you might find that the screw is not suitable. but those are far and few in between, Ram. You're absolutely correct. My implant of choice still remains the headless screw.
Second is, what is your post-op regime after this plate fixation?
So we keep them in a cast for a period of 6 weeks, and then we gradually get them moving. I do an X-ray at 6 weeks, the scaphoid views, and usually by between 8 to 12 weeks, I get them to move. And like Chaitanya and Joe mentioned, the only way we can be absolutely sure whether union has occurred or not occurred is using a CT scan.
And you could
probably do that at 12 to 14 weeks.
Bone graft, isn't it?
Say again?
When you're planning for vascularized bone graft also, this volar plating could be done.
Yeah. So one of the things we found at Wrightington was that we were not able to replicate the results of all the other units. When we looked at our 70 to 75 vascularized grafts that we did, we were not able to replicate the results of the other units. So, you've got to do something that you are capable of doing. You understand? So I have not done this with a vascularized graft. This is what I'm saying.
Navin?
Yeah.
Is it okay that we
still plate questions are there?
Can we
two or three questions are there?
Can we take those questions a little later?
Because he's going, probably he has to go. That's why.
Yeah, I think you need to use your discretion and not repeat.
Okay. I'm using my discretion only.
Yes.
Yeah. I have kept many things, but the one suggestion for the impeachment, somebody said, should we apply the plate with the scaphoid inflection to rule out the impeachment?
If you were to apply it in flexion, you would be left with a persistent humpback, isn't it? I don't understand that.
Yeah.
Question, because the whole objective is to straighten the scaphoid out. So if you were to apply it in flexion, or if you were to over contour the plate, you would end up with a situation where you would cause scapholunate instability, in the sense that you would end up with a compensatory DZ.
Okay. Dr. Mihir Kaka from the Mumbai is asking, what is your post-operative protocol after plating? Cast, any immobilization or nothing?
Yeah, I just answered. I told Ram, we just treat it like you would a non-union fix with a headless screw. So between 6 to 8 weeks in cast, and a CT scan at 12 to 14 weeks. We try and get them moving. We don't put them in cast for longer than 8 weeks.
Is there any chances of loosening the screws? Dr. Amit Varadev is asking.
So far we haven't. The big advantage of this plate is that they're locking screws, and that might explain why we haven't had any loosening.
Okay, I'm skipping some of the questions. Sudhir, you can go ahead, sir.
Yeah, just a quick question to Joe. Joe, is it okay if I ask Randy to speak for 7 minutes about tackling proximal pole fractures in the acute setting? And then you can come in. Is that all right? Do you have that time?
That is fine. Why don't we do both the talks one after the other?
Right.
And then take the questions at the end.
Yeah. Perfect.
I've got a board round in about 20 minutes.
I do understand we're putting a lot of pressure on your time. Randy, Randy, can you come in and share your if Sumedh can stop sharing?
Without stopping also, it will be working. Multiple sharing is enabled.
Okay, Randy Bindra was in UK with Joe Dias. Then he went off to Chicago. He was in Loyola for a while, and now he's in the best part of the world on the Gold Coast in Australia, enjoying himself in his in the late years of his practice, and has been one of the most one of the most wonderful teachers. And more importantly, he was a houseman when I was a registrar in Dr. Tarapurwala's unit. And it's when I used to hear him come down, I always say this story. When I used to hear him come down to the emergency, I would be very upset, because he would have read about what was going to happen and he would ask me questions. I can't forget the one question that he asked me when I was doing a closed section for a distal radius, and he said, "What about the brachioradialis? What is it doing to the fracture?" And I didn't even know where the brachioradialis attached at that time. I was a registrar. Randy, go on, teach us more.
I suffer the same now from my registrars, but they have more access to the internet, and so they can read even faster. So this will be brief. A lot of the anatomy has already been covered, and Joe has talked a little bit about the indications for tackling the proximal pole. So I think one of the issues still remains on what exactly would be the proximal pole fracture. I'll talk a little bit about the anatomy, some management principles, and show a case just to show the surgical approach. Now, this is a micro CT scan image. So when I was in Arkansas, at the University of Arkansas, we used a micro CT to image scaphoids, and so we could get a detailed view of the anatomy. And when you compare that with this study from Compson, which he published in the JBJS, and Compson tried to define what the proximal pole of the scaphoid is. And if you look at literature, some people call it proximal third, which is probably almost waist. Some call it the proximal 25%, and Compson called it the edge of the capitate. And now Joe, through the paper by Singh, have talked more about calling it the proximal 20%. And what Compson said was, so what Compson did, he took these plasticine models of scaphoids on CT, then he put them on a plain X-ray of a broken scaphoid. And following the pattern on a plastic bone, turning it around 360, you kind of realize what the pattern is throughout the bone. And what he said was, if the fracture line is proximal to the scaphocapitate articulation, that is probably a true definition of a proximal pole fracture right there. So the fragment, as you can see, on different views appears different sized. Now, when we did the micro CT, what we found was the proximal pole has the most dense trabeculae, really thick trabeculae. So it's got the best bone in the scaphoid. And in fact, if you look at the number of trabeculae, the bone volume, and other aspects of trabecular thickness, the intertrabecular distance, and the bone volume, you realize that the proximal pole has the best bone. So good screw pitches. And when you look at the blood supply, which Amit showed really well, we know that the supply mainly comes in a retrograde fashion, and there is very little, if any, blood vessels getting in here. Although this paper from Germany done by anatomists on frozen cadavers, on embalmed cadavers, seem to feel that there are some consistent volar blood supplies to the scaphoid, but I'm not sure that has taken on much in surgical literature. What was interesting was when we looked at the micro CT and we looked at the trabecular pattern, it follows the blood vessels that Gelberman showed in the intraosseous supply in 1980. So clearly there are trabeculae and blood vessels go along the trabeculae into this proximal pole. And when you get a fracture here, you can see why you may end up cutting off the blood supply to this thick, dense bone. And hence, when it goes avascular, delayed healing, you can understand why it can easily fragment because it becomes a real brittle piece of bone. We did some studies previously on the measurements of the scaphoid. And one important thing to remember, when you're looking at the proximal pole of the scaphoid, and you're going to put a screw across that bone, very important to remember that in a female, the bone is only about under 4 millimeters wide, and in a male, it's just under 5 millimeters wide. So whatever screw you're putting in from a proximal to distal fashion, you have to have an idea of how big that bone is so that your screw doesn't split that fragment as you're putting it in an antegrade fashion to fix that. And so what I did is just looked at the current screws that are available and to see what the diameter of the screws are. So if you're doing a proximal pole fracture, a really small piece, you probably will be using something like an Acumed Micro, especially in a female where the scaphoid is going to be about 3 millimeters. You want to only use a 2.5 millimeter a micro screw. And you can see the trailing end of the screw is 2.8. So that becomes, a mini would become big, and a standard would break the scaphoid in a female. The KLS Martin, again, it's interesting that the trailing end, the screw is wider than the leading end. So again, there, you would have to use something small, and perhaps the only one that would be appropriate would be maybe a Medartis, which is 2.2 the whole way through, or a Synthes, which is 1.5 the whole way through for really small fragments. And I will sometimes use a screw from the handset, a non-cannulated headed screw that I will bury under the cartilage, which I will show you in a minute. Now, this paper also came from Joe Dias' group, and they looked at this meta-analysis of scaphoids treated non-operatively. And of the 1,147 published in literature, only 5% were proximal. So important to remember, proximal pole is not a common problem. It's only about 6% or 10% of cases. But what they found was 34% non-union rate when they were managed non-operatively. And so, according to this paper from looking at previous reports in literature, your relative risk of a non-union compared to a scaphoid waist fracture is much higher with a proximal pole, 7.5 times higher. So when you are looking at a patient with a proximal pole fracture, poor blood supply, dense bone, higher likelihood of non-union, almost 7.5 times. So this is something you want to take into consideration when you're choosing between operative or non-operative management. The only paper that kind of supports non-operative treatment is the one from Canada by Ruby Grewal. And what Ruby showed was they looked at 5 years or 7 years of their cohort of scaphoid fractures that came through their unit. And in their study, 16% were proximal pole. Now, what's interesting in this paper, they did not define what is proximal pole. 25%, 30%, 20%. I suspect they perhaps included some what we might call a proximal waist, because they said they had an incidence of 16%, quite high. And what's interesting is, of their patients treated in a cast, 90% united assessed by CT, which was very similar to the union rate for waist fractures. And they found, however, that the time to union was a bit longer, so about 3 months in a cast. Once again, as we know with all scaphoid fractures, what are the chances of non-union? What increases the chances? Fracture translation. So again, they said, if a proximal pole fracture of the scaphoid is not moved or there is no displacement on a CT scan, you have a 90% chance of union if you put it in a cast. However, if there's translation or you see a cyst or there's any evidence of comminution of the fragment, you should consider surgery, because then there's a risk of getting non-union. Now, I just want to show one case to show the surgical technique. So if you have a proximal pole and you decide you want to fix it, this is the approach you would use. Now, if you look at this case, unfortunately, I did not do CT scans on this patient. So this is a case from about 15 years ago. And you can see the proximal pole, there's a double shadow. So we were already suspicious that there may be some comminution of that proximal pole. Secondly, when you look at the lateral view, you realize the lunate is in DC. So this is another way to define instability of a scaphoid fracture, is if on the lateral view you have signs of carpal collapse. The approach kind of follows the track of the EPL tendon. So the EPL runs like this. This approach is kind of curved in that fashion. Now, once you open it, you can see we've opened a flap of capsule. This is a flap of capsule that's been elevated. These are the wrist extensor tendons. Here's the EPL tendon. So now you can see the scaphoid, and the fracture is somewhere around here. So as we remove the synovium and the little blood there, just go back a bit. First thing we realize is it looks like a displaced fracture, right? You can see there's a little bit of a cortical step. Next, when we put some wires to get mobility and to try to align the fractures, we realize now there's a coronal split in that proximal pole fragment. So now we've got some wires holding everything together. Now, a single cannulated screw in this case would be inserted from here, and that's right into the plane of that fracture. So in this case, what we ended up doing was putting a screw across from here and one screw from here to get stability. And so we used one screw that was in this fashion that you can see here. And this was a 2mm screw. And this is from the handset. And the other screw was inserted across from here into this fragment. And that's a 1.5mm screw. Now, if you have a headed screw, it's not a big deal, because using a countersink, you can bury the screw beneath the articular cartilage, as you can see there And this patient went on to unite, and you can see we've restored stability in the wrist on that view. Now, the problem with putting a screw in the proximal pole, this is where you have to be careful. Number one, you can split the fragment, and we've all done this. And especially if you're doing a case that's delayed or avascular, the bone is very brittle. I would recommend only use a mini or even a micro screw. Remember, the screw should definitely not be more than 3 millimeters in the trailing edge, or you'll split the screw as you do the final tightening. Because we are doing a dorsal approach, if you haven't flexed the wrist enough and you're approaching the scaphoid from the dorsal aspect, you could end up putting a screw to dorsal and not get the center of the fragment. So it's important to flex the wrist quite a lot so that you can get down the middle and your screw will better capture that fragment. If you're using a conical screw, be careful, it might split it. So be careful of the trailing end of the screw. Oftentimes, when we're putting a screw in the scaphoid, and this is a view in the coronal plane, if you start your screw entry here, what will happen is as you keep inserting the screw to bury the head, you end up losing your purchase on that screw. So when you're treating a proximal pole fracture, very important, you start inserting your screw at the scapholunate ligament here, right there. That way, when you bury your screw, you're still well within the fragment. If you start away from the scapholunate ligament, you'll start to get into the edge of the fragment, and before you know it, you don't have a good fixation. So these are some of the key points to bear in mind technically if you're going to fix these fractures. So what would I recommend, especially if you're treating a proximal pole? CT scan. If there is any displacement, probably you should be fixing it, not suitable for a cast. Proximal pole fracture, as Joe earlier said, it's probably the one indication where you should consider early fixation, simply because if you're going to put it in a cast, it will take 10 to 12 weeks to heal. So your patient has to be prepared to sign up for a longer period of immobilization. If you're going to do an approach to fix it, it's not a big surgery. The scaphoid is right there. You're not cutting any critical ligaments because you're going in that little window between those two ligaments that Amit showed you. So it's a nice small window. You can get good access. However, remember, use micro screws. And if there is comminution, you can use smaller handset screws. Simply bury the head beneath the cartilage. Thank you, Sudhir.
Thanks, Randy. Can you stop sharing, and we'll ask Joe to continue where you left off. If you missed the bus in the beginning, and if you then end up with a non-union, you also have to contend with avascularity of that fragment, a gap, and let's see what options we have from Dr. Joe Dias's talk, and then we'll take questions at the end of that. This session was supposed to end around now, but it looks like we're going to go on for at least an hour more.
Yeah.
So I think some of the delegates can grab their lunch. Navin, have you given out coupons for lunch as well?
Yes, virtual lunch I have served. I'm sending them message.
Right. Randeep, thoroughly enjoyed that as usual, absolutely clear, and something that I can take back to my practice straight away. And I agree with absolutely everything that you've said there. I've been asked to talk about AVN and the proximal scaphoid, particularly related to non-union. And I can summarize the whole talk in 1 second, that my experience of this is incredibly poor. So if you do get osteonecrosis, then probably the better pathway to follow is one of salvage. Remember the triangle that I showed you, you're talking about the very top end, because almost everything else that you do, our experience is not as good as many other people have reported. As Randeep has said, that proximal poles, the proximal 20% completely behave in a different way. And we know, and Randeep will talk to you about SNAC later, that SNAC occurs very much later at this particular location. It is the contained area of the scaphoid. It is the scaphoid is contained between the radius on the one side and the capitate on the other. So things can't move a huge amount, but the big challenge is the vascularity of this end. So the definition that we've used, because this is where it behaves differently, and the literature is confusing about proximal poles, because people will include all this area of the scaphoid as proximal. But this part of the scaphoid behaves completely differently to this tiny part of the scaphoid here. So proximal fifth is the right bit, and as Compson showed, John Compson showed, is the line needs to be going on this side of the capitate. And I'm not entirely certain about the biomechanical relevance of that, but still a very thought-provoking observation that he's made. Now here's a scaphoid fracture where you can see slightly displaced, but look how dense the proximal pole looks. This scaphoid went on, in fact, and joined, and this is what happens to most scaphoid fractures with density. About 1 in 3 will show you radiodensity, but that then resolves as blood supply comes in from the distal part of the scaphoid into the proximal part of the scaphoid. So although radiodensity is very common observation in acute scaphoid fractures, osteonecrosis, which is what happened to this fracture, you can see complete collapse with fragmentation of the proximal pole. Always happens on the convex side and not on the concave side of the scaphoid. But this is a rare beast. I've only ever seen it in the last 40 years, seen it twice. So it's pretty uncommon. And you can see the MR scan showing you reduced signal from the proximal pole. What Tim Davis from Nottingham showed was that, in fact, you can have a black scaphoid on a T2 weighted image. But if you introduce gadolinium, then over time, and therefore if you stabilize that, you will get it to join. The odds are on your side. But if a gadolinium enhanced MR scan do not show you any effect on the transverse carpal artery, which you take. So you take the graft, here's the artery, and you put the vascularized graft there, and then you fix it with a screw. We prefer the Palmer one if you're doing salvage surgery for failed non-union surgery, and then we use the Palmer graft. But it's a very rare indication for avascular necrosis, and I'll explain why. So before we published our papers on proximal pole vascularized graft, this was the state of the literature. Everyone showing Zeidenberg, Mazalos, Matholan, showing 100% union rate if you used vascularized graft. And so Tim Davis and I started looking at our experience. And this is what we found. This is a vascularized graft, which has been put in with a pedicle. It heals well with the distal fragment, but there are two interfaces to heal. So it heals well on the one side, but on the proximal side, where this bit is dead, you can see dead and necrotic, and that bit doesn't join. So you get good union of the vascularized graft on one side and poor union on the other. So we combined our experience, looked at 22 patients, and around the non-union duration was about 2 years, and vascularity, then 3 out of 4 will join. But if it was avascular, it was avascular in 16, then only 12% join. So, and then after we published this paper, every necrotic fracture. So the summary of all this is that in acute proximal pole fractures, 30% of them don't join, but 65% do join. So the odds are still better to get them to join than if you operate. And bear in mind that Randeep has said that operating on this can be quite challenging, especially in females. Thank you.
Thanks, Joe. And the two talks together went in very perfectly well. I'm certain people like Hemant and Ram and Pankaj Ahire are itching to go, because it would have, the flow would have been slightly different, but we've jumped the gun a little bit, so to say. But I think Navin, if there are questions,
Maybe two or three questions we can take.
Yes.
Two questions I'm combining. One is from Anil Bhatt, and one is from Gautam Tiwari. Both are saying almost same. Gautam Tiwari is asking, for proximal fold, if not displaced on CT, would you still fix it? If not, how do you take sure it does not displace? The same way Dr. Anil has asked, is casting in proximal pole purely patient's choice? So, looking both similar questions.
I
Randy.
think, can I start, Randeep, and you add? What we do is we tell the patient what we found. We say it's a proximal pole. We say that the chances, if we treat it in a cast, are 2 out of 3 will join. They know that there is a possibility that it won't join, and it's quite a high odds that it won't join. So we offer them both options, and then if they choose the option of having a cast, then we evaluate them quite early. We evaluate them at about 4 weeks with a CT scan. If there is bridging, then we continue down that pathway. If there is no bridging, then we bail out and we fix. So we change our decision-making only in the sense that we accelerate the assessment of union. In order to just make sure that you are not mindlessly keeping them in a cast for very long periods of time. If they opt for fixation, of course, Randeep will speak to that. Randeep.
Yeah, I agree with Joe that we explain the same thing to them. So for a waist, I tell them you got a 90% chance of healing, but in this type of fracture, your healing is about 70%. So we do get a CT at the start, Joe, just to make sure it's non-displaced. But then we do a 4-week CT for all, the waist and the proximal pole, right? Because if by 4 weeks they're starting to show cyst formation, then that's a negative sign. They're going to get a fixation. What I do tell the proximal pole also is that fixation becomes more difficult afterwards, simply because the piece starts to get harder, gets smaller if it resorbs. So I do kind of, although it's the patient's choice, I think it's they're steered in the direction of surgery more often than not. But if they're averse to having an operation for whatever reason, they get a cast, nothing special, the same short arm cast without including the thumb, nothing special in terms of the cast itself. But I steer them towards an operation earlier on, wherever possible.
You both send them home feeling they haven't made the wrong decision.
Yeah, that's informed choice. You give them the information you want to give them.
Yes.
Yeah. Randy, there is a question from Anil to you. In Ruby's study, they recommend scheduling CT scan early for noting the union. Chai said that to schedule later on. What is your protocol in follow-up? I think you have mentioned already, but again, the same question is asked by Dr. Anil.
Yeah, for non-operative treatment, I do a bit of an earlier CT scan at 4 weeks, simply to look at the scaphoid that's going backwards. So it's not showing signs of healing, but it's actually starting to show cyst formation. So by the time we can get it on the schedule, it'll be 5 or 6 weeks, right? And this was based on Tim Davis, GOAwebinar study, that they published first, where by 4 weeks you can tell if a scaphoid is going to heal or not. When I put a screw inside it, I think I've got enough stability that after 3 weeks I let them mobilize, and then I do my CT scan anywhere between 6 to 10 weeks whenever convenient. Because as Joe said, in those cases you're just looking to confirm a union. Doing an early CT, if it doesn't show union, I'm not going to change what I do. So as long as my investigation doesn't change my treatment, it's not necessary. So I'll do the scan much later. I just let them mobilize, and as long as they don't have pain, I'm not pushing to get further imaging too early. So usually around 8 to 10 weeks.
Okay. For grafting, I'm combining two questions. Is prophylactic grafting indicated in the proximal fold? That has been asked by Dr. Bipin, and Dr. Nandan is asking to the Professor Dias, would a dorsal bone graft be better or a vulvovascularized bone graft is better for proximal pole non-union? Prophylactic grafting and the dorsal and volar graft, the difference?
I think prophylactic grafting is usually not needed if the structure is all right. What we tend to do for proximal poles is we don't routinely do a vascularized bone graft. What we do is pack a lot of cancellous graft taken from the distal radius from the back, but you make a small window at the distal part of the scaphoid, so not in the articular cartilage side, and you pack all the bone there, and you can usually get about half cc to 1 cc of bone packed there before we put in micro screws. The in-between technique between using a vascularized bone graft, pedicled bone graft, and just dead bone, well, not dead bone, but just a bone without an artery, is to implant an artery there, Doy's technique from Japan. And if we are worried about the vascularity, then that is the additional thing that we do. And we just take an artery and plug it in, whichever branch that you have. And that is quite easy to do because you just use it on a needle. You take it from the back, take it out in the front, pull your artery to embed it in. Although you do that, you're doing it without a lot of logic, because the thing that causes collapse of an osteonecrotic bone is revascularization. So revascularization causes collapse. A dead bone remains structurally the same. So you just need to be aware of that as well. Randeep, you want to add anything?
The only time I would do prophylactic grafting is if there's an actual hole in there. And as Joe pointed out, you can get bone graft. So we use a 14 gauge Jamshidi bone marrow biopsy needle. So you can bang that in the radius, get some bone marrow, and you can push it down the screw hole before you put a screw in. But for vascularized graft, I tend to use a dorsal capsular based one, simply because the approach is dorsal. And so it's much easier to put a bone graft with the piece of capsule on it.
Randy, we haven't been very successful using the Jamshidi needle in the distal radius. So very poor yield of the graft. From the iliac crest, of course, it's very good and adequate. Maybe it's
you got to shake it. You got to put it in and shake it.
I need to
before you detach it.
I need to make a trip to Gold Coast.
Okay, now there are questions regarding the cast in the proximal pole. Does it? Is there any change in casting, whether to include the thumb with the proximal cast, or time duration of casting, or in a special way to cast for a proximal pole when you are doing conservative treatment for proximal pole? Yeah.
No special cast, but it does take, if you look at literature, it'll take up to 12 weeks of casting. And that's where in the beginning, when you have that discussion with the patient about surgery versus casting, for a proximal pole, the healing time is much longer. So they really have to understand it could take up to 3 months in a cast.
Yes. Now the question is, how does it is a question from Harvinder Singh. How does instability of the proximal fracture affect your decision making? Is there a role of early fixation in proximal pole?
Yes. If the proximal pole fracture is displaced, and especially those ones that are an avulsion of the scapholunate ligament, you will notice collapse of the carpus, DC pattern of the wrist, as I showed in that case. That would certainly be an indication for early fixation. You wouldn't treat a displaced proximal pole without surgery. They will have a higher risk of non-union.
Oh, condition with the distal radius fracture and the scaphoid fracture, do you treat it differently, or is there any change in the modality? Do you consider it as a more unstable and do a fixation of scaphoid in that and not going for conservative?
I think personally, I don't know about Joe's practice, but if they have scaphoid and radius, I just fix them both because it's much easier for rehabilitation. But I mean, each can be treated on its own merit. So if the radius is non-displaced, you can leave it alone. But if you're going to fix one fracture, it makes sense to fix the other one so you can rehabilitate the wrist, because otherwise you'll end up putting one in a cast, mobilizing the other kind of doesn't make sense.
Yeah,
Joe?
entirely agree with that. If you're going to fix one, then it makes sense to fix both. But because it's completely illogical to fix one and not fix the other, because you're then having to treat one with internal stabilization and treat the second with external stabilization. And therefore you got the worst of both worlds. So you want to make it simple. If fix one, fix both. But if you're not going to fix either because they are undisplaced, then you immobilize both.
Okay, now there are questions about two techniques of the non-union.
Navin?
Yeah.
One second. Ram was waiting to ask a question. He's been very...
Yeah. Please,
okay.
please.
Thank you, Sudhir. A question to both Randy as well as Joe. We know that not all fractures heal with proximal pole non-union surgery. What if the patient come back with no healing despite surgery? What is your backup option? And the patient doesn't have much radial arthritis. Do you go for osteosynthesis with the bone graft again, or would you consider early salvage procedure?
So if I can go, I think Ram, you've asked at the top of the pyramid now, because at some point you've got to make a decision. You're talking about failed non-union surgery.
Yes.
And failed non-union surgery are because of three main reasons. One is there's a technical failure of the implant. The second is because of osteonecrosis. And the third is because of significant osteoarthritis. So you've got three different causes. Now, if there's a technical failure, then you would redo the surgery because you've not got proper stability. If there is avascularity, then you've got to decide whether to go for that 1 in 5 chance of it joining if you put in a vascularized graft, but accept there is a 4 out of 5 chance that it will not join even after second surgery. And if you've got a significant snack, a snack 2 or a snack 3, then you should abandon the surgery. So therefore, your decision is it osteonecrotic or osteoarthritic, in which case you're heading towards not revising your surgery, or whether it is technical with some enhancement of the proximal pole, in which case you might reoperate.
This is exactly what between Nikita and Samir they're going to bring on.
Okay.
A similar scenario, so we can wait for that.
Okay. Now last question about 3 procedures they were asked. One is for what is the experience of the faculty about Meti Russe technique. Another by Tahir is saying how about excision of the avascular fragment and do pyrocarbon proximal scaphoid implant. And third is about scaphoidectomy, excision of scaphoid. These are the 3 procedural questions surfaced.
Randy, you want to speak about that, or are you going to cover that in your talk?
No, I'm not covering the APSI, the pyrocarbon implant, but I have only done about 1 a year. And that's only when a patient comes to me saying, can you put this in my wrist? Because they've been to somebody else and they've been told this pyrocarbon black magic will work. But to be honest, if the, some scaphoids are stable enough, it's like doing a proximal pole excision. So you take out the proximal pole, you put this in. The funny thing is, when I try to read the guide and you try to look at what is the right size, what is the right orientation, there is no guide on it. So every time I do it, I either put something that's probably too small or probably too big. But patients seem to be happy with that pyrocarbon ball. But I don't have long-term follow-up on it. So I will do it, but very rarely. And it's if you're going to take it out, you put something in there. That's what I would say on that.
I think I agree with that because I have visited Philippe Bellemare in Nice, France, and then learned this technique. I have done quite a few cases in England as well as few in India. But you had to be very careful in putting this in right tension. Otherwise, there is also risk of dislocation of this APSI or STEPSI, all these implants. Have to be careful.
Dr. Hemant wanted to say something.
There was a question regarding this Matthieu-Ricci technique.
Yeah.
And I have some experience about treating non-unions with this Matthieu-Ricci technique. And about 155 cases, I think only 2 have resulted in persistent non-union. And I don't use the Matthieu-Ricci technique as classically described by these 2 gentlemen. I use what we call as a modified Matthieu-Ricci, where there is a cortical inlay graft and supplemented with filling all the defects with the cancellous graft from the volar aspect of the radius, and then obviously fixing it with K-wires. And that has given persistently good results. Of course, all of them have been supplemented with plaster, because in India, nobody is really bothered about time to return to work and all those things. They want to heal, and we don't want to get hit by stones.
Yeah, and I think you're going to speak about some of those cases when you.
Yeah, I'm going to show one case.
Yeah.
Of approximately third non-union.
We can leave it.
Thanks a lot, guys. I'm going to have to leave.
Yeah.
I've thoroughly enjoyed it, and thanks for inviting me.
Thank you. Thank you, Professor Dias. Thank you. Thank you. On behalf of
Happy
Gujarat
hour,
Orthopedic
happy hour
Association.
time here.
Yeah, thank you so much. Thank you. It was wonderful.
Thank you.
Bye.
Oh my God. Amit is still awake.
Still
Amit,
awake.
you're still awake or it's morning now?
I mean, you need a kingfisher.
He saw the kingfisher. Send Malia back, yeah. All right. So we'll go on, and I'm going to ask Ram to speak about percutaneous fixation.
Okay, thank you.
Ram has been conducting the Indo-UK shoulder and elbow programs in MIOT, and that's becoming very popular. Screen.
Okay, I'm getting it. Just
Share the screen,
Yeah.
desktop where we all are seen as a video. That is a tip. Don't screen and don't share any other screen.
yeah.
Share only the screen where we are seen.
Yes. Yes.
I went to University of Yale and learned this technique from Dr. Joe Slade. So I will be heavily influenced with that. And we had a lot of learning. For example, 13 years ago, we had these meetings at UK. You see Dr. P.C. Ho, Louis Shaker, and Nick Godot. We did discuss only about scaphoid and DRUJ joint, not about British weather or white. So I'm going to talk about the technique in 5 minutes time. So the success in scaphoid fracture surgery depends on the surgeon, training, dedication, patience, and attention to detail. Second is the infrastructure. You should have a dedicated hand fixation system, implants, low torque gun, and a good image intensifier. Patient compliance and hand therapist. And there are 5 principles. Respect the soft tissue, skin, tendon, nerve. Respect the biology. Do no harm. Stable fixation to allow early mobilization. The scaphoid fracture fixation options are olar or dorsal, open or percutaneous, and using a variety of implants. My choice is dorsal, percutaneous, headless compression screw. So what is my indication for dorsal percutaneous screw fixation? A2 fracture, stable fracture in selected individual, B2 fracture waist, B3 proximal pole, ideal indication, and also a delayed presentation. In some cases of B5, which is a comminuted scaphoid. We'll show examples. Why headless compression screw? Because of the differential pitch, as you put the screw, at the end, you have approximation of both fragments together, and that enables very good interfragmentary compression. Being headless, it doesn't cause any impingement, and it's got a high push apart strength. I had experience with Accutrack screw in the UK, but now currently using these 3 systems available in India: Zimmer, Synthes, and Arthrex headless screws. Why dorsal approach? Logic, number 1, central screw in the mechanical axis of the scaphoid. There is not an oblique direction as in olar. Second, it is good for the proximal pole. It is very difficult to reach this from the olar approach to control. Third, no violation of trapezium. Thereby, the scaphotrapezial arthritis is prevented. As you elegantly shown, the blood supply is olar, and we are avoiding disturbance to blood supply. How I do? First thing first is to use the guide wires, place it, and you mark the projected trajectory of the wire in AP lateral position, and mark this area where you have to do, that is between the 3rd and the 4th compartment. You could make a small nick, make it entirely percutaneous, or you can make a little bit longer incision to see the tendon retract and also do a joystick reduction. Dr. Josley described this method, full flexion of the wrist, and keep the forearm pronated and ulnar deviation. You will see the scaphoid end on like this. And you do the joystick reduction if it is necessary, do percutaneous wiring technique to make it reduced. And occasionally, very occasionally, we might need to use the arthroscope to check the position. Once the guide wire is inserted, you push the guide wire distally, withdraw it. Now you do a proper AP view. While you are inserting, you'll do only the lateral view, but now you could do a full view, AP, oblique, rotate. As far as you're satisfactory, you then advance the screw back and then fix it with the compression screw. I'll show a couple of cases. First one is an 18-year-old lady, fell off a bike. This is sort of, according to Randy's classification, is the proximal pole scaphoid. And that is the fixation with the synthesized screw. And that is 2 weeks after fixation. For type of this fracture, we don't need to put any immobilization. We can give her a creep bandage and ask her to mobilize day 2 of the surgery. So this is the patient at 2 weeks after fixation. You could see the marking still there. And we have made a small transverse incision for cosmetic reasons because it's an 18-year-old girl. And that is the starting of range of movement at 2 weeks. Typically at 6 weeks, they get full range of movement. So second example of a displaced fracture in a 34-year-old man, fall from height. The 3D CT is given to you, but it is so misleading, you will not be able to see the difference. Very important message, go through the CT scan suit. Because of the oblique anatomy of the scaphoid, you have to view every slice, sagittal, coronal. If you see in a coronal picture only off the scaphoid, that means it is a completely displaced fracture, which is in a different direction. So I decided to fix this. This is the surface marking I have made. A slightly bit longer incision made is here because I want to see the extensor tendon and also want to use the wires for joystick reduction of the displaced fragments. This is the EPL tendon, third compartment is being retracted laterally. And then the fourth compartment tendon is retracted ulnar-wise. And you will see the capsule. Make a small neck, longitudinal neck in the capsule. Once you do that, you put the wire from the dorsal approach. You see the wrist completely flexed and pronated position. You cannot do a lateral AP view now. Once you do the pass the wire distally, as you see here in the clinical video, is it playing? Yeah, you could see the 2 wires being pushed distally across. Then this is the joystick wire being holding the fracture. Now you do the screening, make sure you're satisfactory. Then you redraw the wire back dorsally and then measure it. The measurement is very important. It should be 6 millimeter from the length of the scaphoid because you want the screw is totally intraarticular screw to be buried proximally and distally. It should not be too much protruding. Once you do that, you fix with the screw. Take out all the wires and do a final screening. Dynamic fluoroscopy screening. You see that by supinate, pronate, ulnar deviation, radial deviation, all movements you do to check the length of the screws and stability of the fixation. That is ulnar deviation and radial deviation being checked. Once you're happy, you can close the stitch, and that is the patient at 4 weeks follow-up, and that is the 6 months clinical postoperative result. So to summarize, percutaneous fixation, in my experience, is minimally invasive, high union rate, less or no POP, allow good range of movement, and early return to function. Pay meticulous attention to detail in fixation, and you need a lot of patients doing this surgery. And I hope this type of mastery classes, conferences will help you to get into that direction. Thank you very much.
Thank you, Ram. I think we'll ask Pankaj to speak about open fixation, and then we will get Hemant to speak on K-wires, and then we'll take questions all together, and then we'll go on to the more to the non-union side. Yeah.
Thank you.
Okay, so if I can ask Pankaj to start.
Hi, good afternoon, everyone. So I will briefly touch upon, can you hear me well?
Yes, very well.
I'll briefly touch upon the technique of open screw fixation in displaced fractures, and I'll restrict my talk to exactly this. So this is the area that I'm going to talk about, the middle third area. Fortunately, this is the area where maximum scaphoid fractures happen, and this is the area which is the most richly supplied by blood. So the healing is lesser of an issue. as compared to the proximal pole. When this area was studied by CT scan in this paper long ago by Dr. Nakamura, there were some interesting findings. So when the fracture lines happened in the distal third of the waist fracture, I'm not talking about the distal third of the scaphoid, it's the distal third of the waist. And just for orientation, we are talking about dorsal and volar. So this is the proximal and this is the distal. When the fracture lines were in the distal third, we had a volar offset or volar translation and a rotatory displacement. Whereas when the fracture lines were in the proximal third of the waist, then we had a humpback deformity. So these are the three deformities that we get: flexion, as in the humpback deformity; rotation, as in the rotatory translation, and rotatory deformity; and translation, as in the volar offset. Now, not all these are very easily visible on the lateral X-ray or only on a tomogram. Sometimes you require a 3D CT scan, and even for CT scan, the inter-observer error is as much as 20% among the surgeons. Therefore, despite best efforts, all three may remain at the end of fixation, and therefore, perhaps open reduction of a displaced fracture rather than an attempted percutaneous fixation is a better idea. CT scan obviously is useful when you want to treat a fracture conservatively and which looks undisplaced on the X-ray, and you want to confirm that it is undisplaced. Yes, fantastic. That's where CT scan counts much better. So how do we define a displaced scaphoid fracture? Dr. Dias's paper says it's step 1 millimeter, gap more than 1 millimeter. If there is a rotation, as is seen by an unsymmetric gap, if there's an angulation as shown by a humpback deformity, and if there's a dorsal lunate tilt indicating a DC deformity, these are definite indicators of a displaced scaphoid fracture, and these would be definite indications for a surgical fixation as well. Important thing to remember is when you have a displaced fracture, you have about 20% non-union rate. However, even when you operate, the non-union rate still continues to be 7%, which is pretty high. So surgical approach is almost always through a volar approach and through FCR sheet. Dorsal approach is reserved only for the proximal pole fractures and for those fractures who require vascularized bone graft. Schematically, this is the incision which goes across the wrist crease and goes onto the thenar eminence just on the radial side of the FCR sheet. Once the FCR sheet is divided, then we can either divide the capsule in a longitudinal fashion like this, or we can do a nerve sparing approach described by Mark Garcia Diaz. With this approach, perhaps the post-op rehabilitation is supposed to be better proprioception. So this is how it is done. You make two flaps between the radioscaphocapitate ligament and the radioscaphoid ligament. This is again the scheme, and this is the actual exposure through a flap. It's technically difficult because this is a very tiny area. I haven't been doing it regularly yet. I'm still quite happy to just divide the ligament longitudinally as long as I can repair it post-operatively. You need to do a good reduction maneuver. Your healing does depend on good reduction and a stable fixation. Compression is a doubtful element in predicting the healing. So there are two important maneuvers for reduction. One is an indirect reduction, and second is the volar joysticks. I'll just go through to take you through the scheme of reduction. This is a typical lateral view of the wrist, and these are your bones. They are self-explanatory, and these are the bones that we are going to look at. And when you have a waist fracture, this is what we are talking about. Now, typically, even an acute waist fracture typically goes through some amount of carpal collapse, whereby you start getting humpback deformity, the lunate starts looking up. Now, if you want to reduce this effectively, you need to correct the dorsal angulation or the dorsal looking lunate. With that, the proximal fragment of the scaphoid is also looking dorsally. So the steps for this is you start with palmar flexing the wrist, thereby correcting the lunate alignment. And in this position, you insert a K-wire to fix the lunate to the radius. Now you are in effect fixed the proximal pole of the scaphoid in that situation. And now you dorsiflex the wrist again, now which brings the dorsal distal fragment into an alignment. Now, once you have got this, now you need to make a choice of your fixation, whichever you want to. Joystick is typically done through a volar approach. Now the wrist is reversed. This is dorsal, this is volar. We put one K-wire into the distal fragment, one K-wire into the proximal fragment. And we use the joysticks to correct not only the flexion of the scaphoid, but also the rotation. And once an alignment is achieved, then we choose a particular method of fixation. My choice of fixation is a screw fixation over a K-wire fixation. It gives a very stable fixation. The entry point is an important aspect to get the screw perfectly into the scaphoid. So there is a very interesting paper. It says that the trajectory of the screw, which gives you the longest screw in the scaphoid, may not necessarily be the best trajectory. In fact, the trajectory, the yellow lines in this diagram are the ones which are perpendicular to the fracture line. This is where you want to get. And green is the longest one. So the longest screw is not necessarily the best screw. Your trajectory, you should choose a trajectory in such a way that you get as close to perpendicular to the fracture site as possible. So for that, you need to do not hesitate to split open the STT joint in order to get the best entry point. In my practice, removal of part of the trapezium has almost, I'll just skip these examples. So it is very important when you're putting the implant to know your implant very well. There are three varieties of implants that are possible. One is a classical Herbert screw, where the compression is caused only when the proximal threads start engaging the bone fragment, because it works on the principle of differential pitch. Whereas the HCS, which is the diffuse synthesis screw, headless compression screw, the compression is achieved only until the proximal threads engage. Once the proximal threads start engaging, there is no further compression possible. Remember, this is not a differential pitch. This is simply double helix of the same pitch. And the third one, which is the AccuTrack type of screw. AccuTrack is not available in India, but the Arthrex, a fully threaded screw, where compression is achieved throughout the passage of the screw. Once you know your implant well, you will exactly know what is the compression that you need to achieve in your across your fracture. Post-operatively, more post screw fixation, I still put them in 3 weeks of cast if I have got only single screw, and then the patients go on to movements without loading until radiological and clinical healing. Till such time, I put them in a removable splint, at least for first 3 weeks. Thank you very much.
Okay, Sudhir.
Yeah, thanks, Pankaj. Now, can I ask Hemant to present? Hemant, as he already mentioned, I once sat with him at a conference and I went through his computer to look at 150 odd cases treated with K-wires, and I just couldn't believe it. So, Hemant, tell us how you do it.
Yeah. Thanks, Navin bhai and Sudhir, for involving in this.
It's our pleasure, sir.
Pardon?
It is our pleasure.
Yes, thank you. We have heard a lot about the diagnosis and management and all other methods of scaphoid fixation. The method that still is taboo in most of the people's minds is these K-wires. Though we still use K-wires for joysticking, we use it as a guide wire for placing the screws, but still when it comes to using a K-wire for fixing the scaphoid, everybody backs out from these things. Now remember that we are in a place started using K-wires about 15-20 years ago, when K-wire screws were not easily available. The cost was a major factor. we were in a general hospital or in a private setup where probably no insurance or mediclaim cases were there. But then lots of scaphoid fractures used to be around. And so that's why we started using these K-wires in a retrograde fashion. 2 K-wires, 1.5 millimeters in diameter inserted. It took some learning curve initially, and then we got the hold of it or got the hang of it. And probably now I can insert K-wires in about 15-20 minutes. And that's the case where you can see it's about a 6 months post-op. The fracture is completely united. I have nowadays started using CT scan probably more because of peer pressure. I'm more comfortable with taking multiple X-rays, and the diagnosis of the scaphoid union is quite obvious in properly taken X-rays. And that's the function in this patient of a waist fracture. Now, the question always is of a proximal third fracture or proximal pole fractures. What I believe is that these K-wires, as Pankaj rightly said, the compression is not very important. You require a stable fixation, and more so, you require to prevent that interfragmentary mobility. And that's what this K-wires does with combined with a plaster, obviously. Now, again, my preference is to use a 1.5 millimeter K-wires. And this was the fracture which has healed in about 3 months. And this is the function at 1 year post-op. So in all these fractures, when I use K-wires in acute setting, the K-wires have worked. Probably the reason which I have analyzed that the reason why they work is all the K-wires were not inserted with a drill. They were inserted with a hand chuck, with a to and fro motion. So there is no rotatory motion. Probably the reason why this work is also is because when we are inserting these K-wires in a retrograde manner, the distal fragment is pushed in towards the proximal one. So the bone gets compressed in that way, not because of the K-wires. So and secondly, because the K-wires are inserted with a hand chuck, we have experienced no loosening or backouts of the K-wires. Obviously, a plaster is required in these cases. So this K-wire achieves or prevents interfragmentary mobility, which as I've said, and in all our cases of acute fractures and in the waist and proximal third have united. You can see a gross difference in the cost of the K-wires. 2 K-wires cost about 50 rupees as against the screw, which is a minimum 6,000 rupees. It's an undemanding surgery, and there is a very ease of insertion. The K-wire insertion is very simple. Obviously, you require a C-arm for all this. The minimum instruments are required. You require a good K-wire cutter, good sharp cutter, and you require a T-handle with chuck. Even for placement of the guide wire or for the screw placement, you require to master the art of inserting a K-wire. Either you can go from the dorsal approach or the volar approach, as has been said in this webinar, but you require to master the art of placing a K-wire in the proper way. Unfortunately, for the K-wires, there have been no references, so I cannot say that this is an evidence-based study. And the only evidence paper I've found was as late as 2018, when there was a K-wire. The paper mentioned that internal fixation with K-wires is probably as efficient as rigid screw fixation. So we come to the question of non-unions in a scaphoid, and you can see various causes of non-unions: properly applied plasters, neglected injuries, improperly applied screws. And now the best part about these K-wires is that the master himself, Dr. Fernandez, who is famous for his Fernandez technique of a iliac crest bone graft, has also mentioned or endorsed that K-wire should be used in proximal third non-unions. And screw fixation is contraindicated in these cases because there is very little bone left. And this paper was published in Hand Clinics of North America in 2019. And so we come to this illustrative case where there is a cyst formation and there is a proximal pole non-union. This patient presented 11 months after the injury. And as I've said, I use this modified Matteucci technique where I use a cortical stud graft and supplemental cancellous graft. There is huge amount of graft that can be harvested from the volar aspect of the distal radius. And that's the non-union site that has been prepared, and a bone graft has been taken from the cortical graft has been taken from the distal radius, and that's the bone strut which is held in the hand prior to implantation, and that's the bone strut which is inserted in between the two ends of the scaphoid after correction of the deformity, and so you get a lot of space there. You require some effort and some maneuvering to put this cortical strut in. Once this cortical strut goes in, the scaphoid really becomes very stable. All you require is a K-wire to just additionally support this fixation. And these are the two K-wires that were inserted in this case. I don't use two K-wires now. I probably use only a single K-wire, 1.5 or 1 millimeter in diameter, because I feel that you require more of grafts and less of K-wires for union in a non-union. And that was this case. This is a 6 months post-op. The fracture is completely united. This is 7 months. Between 6 and 7, I removed these K-wires. And that's at 1 year. It's completely regained its function and the power of the hand. And this patient had come to me for some other reason. And this is 10 years post-op of the same patient, which was treated for a proximal third non-union. Lots of other papers, they also endorse the fact that K-wires are very good for non-unions, especially proximal third non-unions. This paper says that it has got a superior or equal union rates. This paper mentions that it's an undemanding operation, with there are few complications, and they also recommend it for proximal pole non-union. This paper says that there are advantages of cost, ease of insertion, and accessibility, because K-wires are universally available. And I think, as you rightly said, this is a method of choice for developing countries. This is a last case, a very illustrative case of the role of immobility of fracture fragments. This patient presented in October 2005. He was given a cast, but he removed it on his own. And he presented 7 months later with an ununited fracture of the scaphoid. He refused open reduction, but after a lot of counseling, he agreed for a percutaneous K-wire fixation after 7 months of fracture. The fracture went on to heal with a retrograde K-wires. 2 K-wires were inserted, as you can see. And this is 10 months later when the cast was removed. That's it after 3 months. This is after 2 years. And the patient ran, I think he went lost for follow-up. He presented for some pain, and that the K-wire was causing some pain at the scaphotrapezial joint. So we removed the K-wires after 2 years. And this is his function after 36 months, that is 3 years. He's got full function, the bone is completely united. So, friends, the scaphoid fractures need stabilization and not compression, and K-wire works. I thank you all for your attention.
Thank you, Hemant. Navin, I'm sure some questions have come up.
Just a minute. Yeah. So the first comment is from Dr. Anil Bhatt for Dr. Hemant. For Dr. Hemant, sir, you personify that it is the archer and not the arrow what is important in our practice. This is just a comment.
Yeah, I would agree. I think both are important. If the archer fires a blunt arrow, nothing will happen.
Okay. K-wires are threaded or smooth?
These are smooth K-wires, but trocar tipped.
And I think this question is to Pankaj. How can an R3 screw achieve compression when there is no smooth shank, or that the drill hole is equal to the thread diameter? They wanted to know technicality about the R3 screw.
Yeah. The R3 screw has a graded pitch. It's a continuous thread with a graded pitch. So as the screw starts advancing, every subsequent thread will be of a smaller and smaller pitch. Thereby, the tip of the screw will advance more in the distal fragment and less in the proximal fragment, and thereby compression is achieved.
So it is a tapered screw. It's a tapered screw.
It's not only a tapered screw. The pitch also is different. Keeps on reducing as you come from distal to proximal.
It's the same model like accumate screw.
Absolutely.
The differential clip. Okay. But you have to put the screw fully inside the bone to get the compression of the trailing fragment.
There is a comment again to Dr. Pankaj. As the scaphoid reduces in dorsiflexion of the wrist using the dorsal approach with the extreme palmar flexion, isn't it a bit contradictory? This is a comment, huh? Nothing like a question. If you want to answer.
Yeah, I mean, you need to choose a maneuver which will reduce the fracture and hold it temporarily using KYLs. So even when you want to put a screw from the dorsum, okay, you still need to do all the maneuvers that are required for reduction of the fracture. Perhaps hold it temporarily with a suboptimal wire, and then dorsiflex the wrist in order to put a wire in the center from proximal to distal. So if any maneuver which facilitates screw insertion but disturbs the fracture alignment is not going to work.
Okay. Now the questions are coming for the Randy, I think. For proximal pole, you use a dorsal approach. So invariably take a dorsal graft. Do you think a volar distal graft increases the vascularity of the proximal pole due to the corticotomy itself in the distal radius? This question is asked by Dr. Hiten Mathur.
Dr. Mathur, the thing is, when you do a volar approach, you just do not get good enough access to the proximal pole. You can put some graft in there, but if you do fixation, you would have to do KYs like Hemant shows, because it would have to be antegrade. But if you believe in compression, which I still do, you would have to go dorsally. So you can go antegrade and you can compress the small fragment to the big fragment. So I use bone graft from the dorsal radius. I use the graft described by Dean Soterianos, which has a capsular flat. It's actually the 3-4 interspace bone with a strip of dorsal capsule. That strip of dorsal capsule gives you access to the fracture as well as raises a graft. And you can leave that capsulotomy open. You don't close it, so you don't lose palmar flexion. So what I do is I go dorsally. I put my screw a little bit more volar than usual. So I get my screw fixation first, because the piece is so small, you'll displace it. So screw fixation first, then cut a trough across the fracture, and then insert the graft. You're still doing a corticotomy because you're taking a dorsal graft. So the pain relieving effect of corticotomy is still there. Plus, I'm adding a proximal posterior introstatic nerve neurectomy because it's part of the pedicle of that graft anyway. So everything helps.
Okay.
But dorsal gives you a better approach to the fragment.
Randy, this is a question from Dr. Jyotindra Pandit. Is there a role of close reduction and a plaster immobilization of displaced fractures of the scaphoid? Generalized, it's nothing like
yes.
proximal pole or like.
When I was a trainee, there was a lot of stress on wrist dorsiflexion and radial deviation to close the gap on the scaphoid. But subsequent studies have shown that once it's displaced, it's very difficult to maintain it, to reduce it, and to maintain by close technique. So largely, the current concept is if the fracture is displaced, you need to reduce it open and fix it. You can fix it with K-wires or screws or whatever, but you cannot get a displaced fracture reduced and held reliably with a cast.
Okay.
Can I just
yeah, please.
It's a very interesting question, because we've come to, sitting and listening for 2.5 hours, we've come to this thought that if it's 2 millimeters, oh my God, it's not going to heal. That's not a fact. In fact, they will heal, but they'll heal 17 times. And Joe Dias's paper is there on this one. It's a very old paper, but 17 times chances of a non-union are increased. So you're actually taking a risk, but it will heal. Many of them do heal even if they're displaced. And that's what even the SWIFT trial was showing, that even though they were displaced, some of them did heal. So they can heal, but you're now taking a big chance. At 6 weeks and 4 to 6 weeks, that's the time when you would want to change tracks and move towards fixation if it requires that. So you need to be vigilant if you're going to cast a displaced scaphoid fracture.
again, question to Dr. Rendy. Can the undisplaced proximal pole be treated percutaneously or always open?
No, I would do it percutaneously when it's undisplaced. So if a patient came to me with a fresh fracture and it's not displaced, I would do a CT scan. If it's not comminuted, then I will do a percutaneous fixation like I do for all waist fractures with a mini dorsal approach. It's only the case that I showed you with the open reduction was because it was a comminuted fragment.
Yes.
Okay, Dr. Anil has again asked a question to you. Is there any role of excision of that small fragment, less than 20% of the proximal pole, and suture scapholinate ligament to the main bone?
It can be done, but it has to be a really small avulsion. So I'm talking about even less than 20%. It is a true avulsion fracture of the scapholinate ligament. You literally, when you do the CT scan, it's almost the dorsal part, not even the whole through and through. Those are the kind, yes, I will take it out, repair the ligament, but I will put K wires across the scaphocapitate joint and hold it for 6 weeks. Otherwise, you won't be able to correct the flexion of the scaphoid. So yes, there is a role in a true scapholinate avulsion fracture of doing excision and ligament repair.
Okay, there are two questions from Dr. Tejas Gandhi. Any role of dynamic CT or dynamic radiology for instability? And another question is, any role of BMP in delayed or a partial uniting scaphoid fracture?
So the dynamic CT or 4D CT requires a painless wrist to move it. So when you got a fracture and a painful wrist, it's kind of hard to assess. So probably limited value in an acute case. In a chronic case, in a non-union, if you're trying to decide in an asymptomatic non-union, is the patient got a fibrous union and they're maintaining the normal carpal kinematics? That's when I would do a 4D CT scan of both wrists at the same time to see if the asymptomatic non-union is causing change in carpal kinematics. As far as BMP is concerned, BMP is uncontrolled ossification. So you'll get bone formation in the capsule and everywhere. But just simply using cancellous graft packed into the non-union with or without vascularization is probably as good as BMP. I find BMP a bit uncontrolled.
Okay. Again, the question is...
Pankaj has a point on that. Pankaj?
Yeah.
Unmute yourself.
Unmute.
Pankaj. Yeah, I have a question actually. If you have a well-aligned fibrous non-union, would you leave it alone?
Is it if it's asymptomatic,
yes,
looks aligned, and they have no pain, then I simply bring them back and your yearly X-ray for a year or two, and then that's it. If it's not progressive into a it's not progressing to carpal collapse, it's giving no symptoms, I can't sell them an operation of which the outcome is uncertain.
Right.
Again, a question from Dr. Anil to Rendy. Have seen few non-unions in very distal fractures, your experience?
Very distal non-unions can occur. And those are the times when I actually use the plate. Because with a very distal non-union, it's hard to get a screw in because of the trapezium. So your screw only captures the edge of the bone. That's the case I find that the plate works the best. I use the plate that Sumedh shows, but I actually cut off the proximal third of the plate, so there's no impingement on the proximal pole. And that way I can get 2 screws in a distal fragment, a couple in the shaft. So I see that mainly in teenagers, not usually in the older patient.
Okay. In any case, Dr. Rajesh is asking you from the Nagpur, any case where we open fracture scaphoid from the both volar and dorsal approach, hold it and with towel clip and fix. Is there any condition where you have a dual approach?
I have never done it simultaneously. I have done it simultaneously as part of a perilunate dislocation, right? Or as part of a complex distal radius fracture with a carpal injury. But for pure scaphoid fracture, I've never done it at the same time. Now, occasionally, I've done a volar graft, and I may come back 3 months later because that failed, and I'm doing a vascular pedicle from the dorsal aspect. So those are the times when I would do a volar and dorsal, but different indications.
Okay.
Right. Can we go on?
Yes, only one comment is there from Dr. Adipalli Srinivas. Sir, it is a really demystifying till today. This is the best and complete webinar in your series, especially the anatomy part. and now it was highest touch 6731. So very thankful to each one. And Randy, probably sun is going down, so from your gallery we are not seeing the sunlight.
That's right. My afternoon in the balcony.
Okay.
We are not finishing. We still have. Randy.
No, we are not finishing. We are not finishing. This is just a filler, sir.
We'll allow him to go to the refrigerator and refill that beer. Yeah,
I'm seeing little less light on his face. That's why.
Yes, definitely.
Very, very observant. You're getting to be a master at this. I just wanted to quickly show this. This is Pankaj spoke about leaving in a K-wire so that there is no rotation when you're fixing your scaphoid. So you have two K-wires inside the scaphoid. Now I have done this a few times, and what happened is, and I got these slides from John Capo. I have my own slides which are following. But what happens is, if the K-wires are crossing inside the bone and very close to each other, as the drill bit goes through, this is what can happen. So the drill bit is extremely thin. It's a cannulated, very thin-walled drill bit. So as it goes through, if the two wires are extremely close, just imagine the force of your torque of the drill is now is exerted, and what is resisting the drill from moving is the K-wire, which is stronger than the drill bit. And the K-wire shatters inside and then leaves those drill bits in pieces inside. So you need to then remove those drill bits, because it's not an implantable material. It's martensitic steel and has a high carbon content and can cause corrosion. And of course, if he goes with an X-ray like this, competitor, you're going to have problems. So I did have to go in, open a percutaneous one, open it, and then remove those pieces and then subsequently fix it. So that's just something that you should be aware of when you're dealing with 2 K wires inside. So see to it that the 2 K wires are separate enough to allow that 1 or 1.2 millimeters of the drill bit wall to go in between the two. Pankaj, any comments on that?
Yeah, I was about to ask for permission to comment. So the first K wire that you put, which is going to be a holding wire, and the second one, which is going to be the screw wire, or vice versa, these have to be deliberate attempts. It should not be that you attempted one central wire, it did not go through, then you put a second central wire, and then now you want to retain one. No, that's when they are very likely to cross, because both were attempted to be ideal wires.
Correct.
Yeah, so the term used is the holding wire needs to be deliberately a suboptimal wire. It needs to be at one edge or just maybe skirting the fracture. The purpose of this wire is simply to resist the torque that is generated by the screw.
Right.
That's only the comment here.
Okay, so I'll go on with my presentation now quickly on the humpback deformity. For some reason, I'm unable to cause it to go to full screen. I don't know why.
So you click on the slide first.
Yeah.
Then, okay.
Right. So the humpback deformity, and for a long time, I've been trying to understand why is it called the humpback deformity. Until I put these two together, I didn't know that it looks exactly like the humpback whale. So this is a humpback deformity, which tells you that 2-3 things. One of the things that you need to look for is this little so-called, some people call this callus. That's basically a wider distal part of the bone, which is overhanging the narrower proximal part, and therefore it's overhanging on the sides. And what you're seeing is not callus or attempts at healing. It's just a wider bone overlapping a narrower bone. So that's number one. And number two is you see a large gap or cystic area, which tells you that this is a humpback deformity. And that means the distal part of the scaphoid has flexed, while the proximal part has gone with the lunate into extension, causing you a DC deformity. So what constitutes the humpback is volar shortening, is angulation of the scaphoid with apex dorsal, dorsal shift of the distal fragment. So it's not that, unless you reduce it and translate that dorsal shift, you're not going to get a good reduction. And of course, there will be DC because now the lunate is free to move with the triquetrum into extension. So it's important to know this. A little bit of the anatomy comes back in here, that the DIC is attached to the scaphoid, as we can see here, and it's very close to this dorsal ridge. So any fracture, and that's the attachment of the DIC there, and any fracture that goes distal to that, as opposed to the ones that are proximal to that, will be any fracture that's distal to the DIC can cause a humpback deformity because the support of the DIC is now gone and the rest of it can then flip forward. So with movements of the carpus, that tends to move and you start getting problems. So anything that's proximal to that, where the DIC support is there, you'll see that they are maintained and you tend to get fibrous non-unions which retain the height. Why does bone loss occur when you get these deformities? And you can see this once we've opened and I'm flexing and extending, and you can see the gap there. And each flexion and extension movement is going to cause the bone to rub against bone and slowly and surely erode that bone and cause what is known as bone loss, or what you consider to be bone loss. That means the height of the scaphoid has gone down. So humpback, so what? Why not just fix it? Well, because 5 degrees of angulation into flexion causes 24 degrees of radiocarpal extension loss. When that increases to 15 degrees, then you have complete radiocarpal extension loss. Remember, midcarpal movements are still present, and midcarpal movements are responsible for 30 to 40% of extension. So you still have some extension, but it's happening at the midcarpal joint. And when this increases to 30 degrees, even the midcarpal movement is lost. So whereas this gets worse and worse, you find that the wrist becomes stiffer and stiffer and stiffer. So humpback means you need to come back and restore the height. There are different ways of doing that or understanding how to look at that, but we won't go into these details. We've also had Chaitanya speak about this earlier. Quickly to show you one of these cases, the nerve sparing approach, I won't belabor this one. We've been through that. The only thing is to understand that when you retain the nerves in the ligaments, after you repaired it, if the patient is going to fall down sometime in the remote future, the reactions of his muscle contraction will depend upon whether there are impulses going back to the brain. So that's the reason why proprioception is important post this repair and healing. So therefore, you must try and respect this. A lot of people think it's not very important, but I think if we can save that, it might be useful. So we've spoken a lot about joysticks, and here's one very clean and clear image, some images that will tell you how it helps. You can see that I've here, in this case, I've retained the blood, the radial artery branch that goes to the superficial palmar arch. Sometimes it's not possible to retain it when you're working in this region. So you might have to sacrifice that, but be careful that you ligate it properly. This is a branch of this does go into the volar supply. So you would be taking away some of the blood supply to the distal part of the scaphoid. So as far as possible, try and retain it. Oftentimes it's not possible. So this is what's happening. If you notice the fracture gap with the pre-placed joysticks, the moment you move them apart, you can see the bone gap, and you can see the reason why you need a structural filling of that defect. So the same thing seen on the X-ray, and when you have the joysticks in place, you see the mid-carpal joint is not seen very clearly. There's a collapse there, so everything looks a little bunched up. The moment you pull them apart and you see the smile on the mid-carpal joint, the smiley of the mid-carpal joint is retained. So when you retain the height or you restore the height of the scaphoid, you bring all these joints back into place, and therefore you're going to get a good result. Sometimes when there's so much of bone loss, just a simple traction view will show you how much of that bone has been eroded. And what you need to take is a tricortical wedge. I don't use saws. I use a nice rongeur as seen here. It's a nice small wedge which you can measure off and use You may use a distractor, a self-retaining spreader, which will help you in measuring and also in slotting in your graft. Once the graft is slotted in, as you can see here, this is the graft, then you need to tailor off the sides so that it doesn't overhang too much. Check the position and fix it down with a screw. And we've seen how we fix it down with the screw, and you can see here that the graft has been impaled by the screw quite clearly. And that in 16 weeks, he has a good range of movements, and that's his x-ray at that time. So this is the Fisk-Fernandez. Fisk actually described it from the radial side. Fernandez went on in 1984 to try and use the purely volar approach. And the 2019 paper that Hemant was talking about, I'll probably revert to it later. But even in that, he speaks about how good these grafts do in these instances. We won't go into any more details. I will, I think, skip questions at this stage.
Okay.
And just 1 second, let me stop sharing. Yeah, okay. So we'll skip questions at this stage and we'll go on to, where are we now? Okay, we're going to go on to Nikita, who's been very quiet through the morning. And she's going to tell us something that when there was a question that was asked to Joe about vascularized grafts and what if they fail and what if you have a problem. So she's going to present us a case of failure of vascularized grafts. Nikita.
So the question is, sorry, there's a mistake on the first slide. I'm so sorry for that. But the question is, do vascularized grafts fail? So this is a case of a 32-year-old male who presented to us after 1 year of after his injury and had a non-union of the proximal pole of the scaphoid. And the MRI showed there was some retained vascularity in the proximal pole. And like Dr. Amit Gupta showed us that the extraosseous vessels of the distal radius have very constant spatial relationships with the anatomic landmarks, which makes it a little easier to, take a graft from. And there are various studies that show that vascularized grafts have superior results in comparison with the conventional grafts from the iliac crest. So we went ahead and did a 1-2 ICSRA graft and fixed it with a screw. So at 5 weeks after we removed the plaster, this is the X-ray that we saw. And in this X-ray, it looks like the graft is taking up very well. There's no fracture gap. And the scaphoid looks good. But at follow-up 5 months post-operatively, we could see some demineralization and the lateral cortex shows some cystic change and there's a gap. And this patient was immobilized in a splint after the cast removal. This patient was immobilized in a splint for 3 to 4 months. And then at 19 months, we saw that there was a good fracture gap which showed a persistent non-union of the proximal pole. That means the graft had not really incorporated. And like Dr. Joe Dias said, that in these patients, there's many a times their graft does not incorporate into the proximal fragment. So that is what exactly happened in this patient. He had good range of motion, but at every moment he had, the movement was very painful and he couldn't get back to his activities or his job because of the pain. It was really disabling. And on a CT scan, we also confirmed the non-union and there was a DC deformity. And the MRI showed that the proximal fragment was completely avascular. So what do we do next? There have been papers that show that there are good results with the 1-2 ICSRA, but like Dr. Joe Dias showed us that especially when the patient has a preoperative avascular necrosis of the proximal pole, they do not do very well with these grafts. So now what are the alternatives? Is there an option for these patients and what do we do next? So to talk about this, I would like to invite Dr. Samir Kumta, who will be talking in detail about the alternative method of fixing these fractures.
Yeah, just stop sharing your screen and we'll ask Samir to share. Sorry, Samir, you sat through a lot of technical scaphoid orthopedic carpentry. Now it's your turn to tell us, when we fail, despite all our information, what can we do?
Sorry, hello everybody. I'm just trying to get my presentation loaded.
Yes, it's loaded now. No, now you stop sharing.
Yeah, I will share now. Okay, hello everybody. This is Dr. Samir Kumta from Mumbai. So before I go on to better options for vascularized bone grafts, let me give you a little bit of perspective as to where I stand and how I got involved with scaphoid. So I am basically a plastic surgeon, and my main focus is reconstructive microsurgery. Actually, I'd like to remind Sudhir that this is the 27th year of our association. We first operated together in April of 1994, and the first case we did together was in fact a toe-to-hand transfer.
Samir, can you make full screen for the viewers? PowerPoint show.
Yeah, so I'm okay.
Yeah,
it's been a long and very fruitful association with Sudhir. And so how did we get involved with scaphoid fractures? So as a plastic surgeon, I hardly ever see any patients with primary scaphoid injuries, but they all come to Sudhir, and Sudhir, ever since he's been practicing, has been treating scaphoid fractures. And he's always used whatever is the standard of care at that time. But in his practice, he did come across some fractures that did not unite. And he also got patients who had been treated by others, and when they got into non-union, came to him. So not all fractures that we got to treat were treated by us. Some treated by us and went to non-union, some treated by others. So when did we, or when we face non-union, the standard method of treatment for non-unions has been bone grafts. And if you know very well, bone grafts do undergo certain biological changes. If you have non-vascularized bone grafts, they depend on vascularity, on contact with vascularized bone on both sides. And this is actually the basic problem why certain fractures of the scaphoid do not heal even when they are bone grafted. And the reason for that is actually the proximal pole. And so our experience with vascular bone grafts has been mainly for fractures of the proximal pole, where the proximal pole, has been shown by Dr. Gupta, has poor blood supply, and the blood supply comes in from the distal bone. And when there's a fracture, then the blood supply that comes in from distal bone is cut off. So the proximal pole undergoes either sclerosis or becomes avascular. And if you are faced with a non-union in this area and you put in a non-vascularized bone graft, that bone graft is in contact with vascularized distal scaphoid, but the proximal scaphoid is avascular. And so this bone graft doesn't have vascularized bone in contact with it on either side, which is why it often fails. And which is why the role of vascularized bone grafts have come in. Now, before we didn't get into the MFC right in the beginning, we tried other methods of vascularized bone grafts, one of which was shown by Nikita. We tried also the second metacarpal bone graft based on the first dorsal metacarpal artery. We tried other bone grafts based on perforators from the radial artery to the radius. And by and large, all of them fail. And my personal impression, or a reason why these bone grafts fail, is the fact that most of these pedicle vascular bone grafts have been described in the Western literature. Unfortunately, the sort of the size of the limbs, or the general, compared to the Indian patient, who is a little small built as compared to the European or the American patient. So the vessels that they describe, which are very good, when we actually explore in our patients, those vessels are very, very tiny. And sometimes the blood supply from those vessels is unreliable. Also, there is no quantification of how much volume of bone graft will be supported by a particular vessel. So in absence of quantification and when faced with very small vessels as compared to the Western patient, we have had lots of failures with these pedicled bone grafts from the region, like the second metacarpal or the radius, which is why then we looked at looking at better vascularized bone grafts. And the next best option we felt was the medial femoral condyle. So why the medial femoral condyle? So in reconstructive surgery, the vascularized bone grafts that have been commonly used are the fibula, the vascularized iliac crest, and the scapula. But when we come to small requirements, very small bone grafts, we had very few options till this medial femoral condyle was described by a Japanese plastic surgeon named Doi. And he first described it for scaphoid non-unions. Having said that, the MFC or medial femoral condyle has now become the blue-eyed boy of all reconstructive surgeons. It has applications as wide-ranging as for laryngeal wall reconstruction, for nasal reconstruction, for reconstruction of non-unions in smaller long bones, like the radius, ulna, the metacarpal, the phalanges, and the metatarsals. So it now has, I mean, everyone is using this for non-unions anywhere and everywhere. So it's suddenly become a very, very useful and viable option. So in this talk, I'll give you an overview of the MFC and how we actually use it for specifically for scaphoid non-unions. And so this is an X-ray that shows clearly how the proximal pole, that is avascular in this case, if you put in a ordinary non-vascular bone graft, this is not going to unite at this end, and eventually the non-union fails. So which is why putting a vascularized bone graft, which brings in its own blood supply, is useful for non-unions like this. And this is what we do. This is a non-union. And as you can see here, the joystick maneuver, I call it the Warrior maneuver, but it's universally known as the joystick maneuver. So this is very important because most of these fractures or non-unions of the proximal pole, there is a flexion of the scaphoid. So when you put in these joysticks, you open up the fracture and correct the flexion and put in a bone graft of adequate size. Not only that, when you put the joysticks, additionally what we do is core out and actually make the proximal pole very hollow and remove all the unhealthy bone inside and leave only the cortical shell outside. So this is how the gap has been created, and this is the gap in which we accurately measure this gap and tailor our bone graft to fit into that gap. So I'll not go into the investigation that these have been described by everybody, but this is the MRI showing the avascularity of the proximal pole. So the indications in our practice for vascularized medial femoral condyle have been the proximal pole fracture non-unions, which were either untreated or neglected and came to us maybe 6 months, maybe a year later with continued pain in the wrist and diagnosed as fractures of the scaphoid proximal pole. Or those patients who have undergone treatment, conservative treatment which failed, or patients who had undergone failed fixation, failed bone grafting. And in most of these patients, the proximal pole was either sclerotic or avascular, and which is why we had to resort to this. The only contraindication for us was if the surrounding bones or the show arthritic changes, then the treatment, as Joe Dias also mentioned, then the focus of your treatment changes to not to achieving union, but to then to try some form of limited fusion to reverse the changes of arthritis or to control the pain. So going to the technical aspects of the procedure, we normally, so that two teams can operate simultaneously, we take the opposite thigh and put a very high upper thigh tourniquet, and the lower limb is placed abducted and laterally rotated at the hip joint and the knee joint is flexed so that we have access to the medial surface of the thigh. And this is our markings, and this is the position that we give. So this is the line of the incision. This is the upper medial, this is the patella. This is the marking of the femoral condyle area. This is the vastus medialis. And we take an incision over the vastus medialis, which we deepen down into the skin and to the fascia over the vastus medialis. Now, a brief description of the vascular anatomy. Why we chose this vascular medial femoral condyle was the fact that it has a very, very reliable blood supply, the descending genicular artery, which is a good size vessel between 1 and 2 millimeters in size, sometimes bigger, and which is very reliable. Not only that, it goes and supplies a big area of the medial femoral condyle, which does not take part in articulation. And not only that, it has a big arborization network all over the surface of the medial femoral condyle. And one of its branches, the transverse branches, goes to the articular surface. And if we need a graft which includes articular surface or articular cartilage, for example, if we need to replace the entire proximal pole of the scaphoid, this is the branch we trace and take out a piece of bone in this area. And we actually did this in one of our patients, which I will show you later. So this is the flap dissection. This is how the fascia over the vastus medialis, which is retracted anteriorly, you can see. And as you, we start distally and then move proximally. So when you open and expose the medial femoral condyle by retracting the vastus medialis, immediately this leash of vessels over the medial femoral condyle comes into view. And then as you retract this backwards and the vastus medialis forward, you will come to see the vessel. And this vessel is then traced proximally up to its origin from the distal femoral artery. This is the descending genicular artery. And this is the vessel that is being traced more proximally. And this is now the entire area of the graft identified, the branches and are clipped. A tip for those who are going in for this, do use for ligating all the branches, either use bipolar for the very small branches or use the smallest size liga clips available, because once you put them in the wrist, sometimes these liga clips poke under the skin and trouble the patient. A few of our patients had come back and had to have these clips, the big ones, removed. So this is the entire vessel that has been dissected. There's an artery and a vein, which, as you can see, are pretty good size. And this is the network over the medial femoral condyle. Now, this is where Dr. Warrier comes in. He has already prepared the scaphoid region, as I've shown, by coring out the proximal pole and creating a space in which to fit this bone graft. And once we get an idea of how much bone graft is required, then we have so much area to plan where to take our bone graft from. So we go to the area where there is maximum blood vessels, as probably this one, and then cut out the graft in the required shape and to the required depth. So once that is done, so this is the marking of the graft, and this is the graft that has been cut out and removed. This is the pedicle, the artery and the vein, and this is a piece of graft. And so the distal limit of the graft is 2 centimeters short of the joint line. The proximal limit is short of the condyle and shaft junction. Medially, we can go up to the attachments of the medial collateral ligament, and the cancellous bone can be harvested from the same side. So what we actually do is take a block, a small block, maybe 5 by 7 or 5 by 5 millimeter thickness, and core out a little more cancellous bone. And the hollow shell of the proximal pole is packed with little bit of cancellous bone, and then the vascular bone graft is interposed in the gap. So this is the donor defect, which we fill. We don't use bone wax, but we fill it with the gel foam and close with a drain. I will not go into the video. If anybody wishes to see the video, they can email me privately and I can share the video with them.
Can you put just the link so that they can go to the link if it is in the YouTube?
Yeah, I don't think it's on YouTube.
Okay, fine.
Okay, but Meditube is there on Meditube.
Okay.
Yeah. So, so for the approach to the scaphoid, initially we did try a few dorsal approaches, but we found the volar approach better to fit in the bone graft and to get the vascular pedicle to the radial artery. It is much easier. Through the dorsal approach, we plug in the vessels to the radial artery in the snub box area. But for the volar approach, we go to the distal radial artery in the distal part of the forearm. And in the snuff box area, access to the radial artery and to do an end-to-side anastomy is a little difficult. So we prefer to the volar approach now. And this is the joysticks that have been put in and the gap created. And this is how the bone graft has been placed, and it fits snugly. So you should not have too big a bone graft, because then it pokes out and maybe sometimes cause a restriction or a bump under the wrist or the front of the forearm, which is unsightly and which is sometimes painful. So the bone graft has to be of adequate size, trimmed so that it does not pout out of the gap. And this is now the vessels have been joined. This is the graft revascular. You can see good bleeding surface of the graft. So only in one situation, one patient, we've had a slight anatomical anomaly where the dominant vessel was not the descending genicular, but it was the superior medial genicular artery, which comes actually from the popliteal artery transversely and supplies this area. So also in some situations where if you feel patients have had multiple approach exposures or the skin is tight, there is an option to take a small paddle of skin based on a perforator that goes to the skin, and then you can replace the scar and with a small island of skin. We have not had any reason to do it so far in our practice, but last year I visited the University of Pennsylvania unit, and I saw them doing a vascularized bone graft, and they used a small island of skin. Now the case that Nikita showed you earlier. Sorry. So in this patient, as you can see, the proximal pole has gone totally atrophic and collapsed. So there is no way of retaining the proximal pole. So in this patient, we actually 3D printed an image of the opposite scaphoid, and with using that, we got an image by subtraction of what actually we need to put in. And we cored the medial femoral condyle exactly to match that shape, and then we put it in to replace the proximal pole. So this was done in only one patient. And this is again for fixation. For a few patients, we have used a cannulated screw like in this one. But for the majority of our patients, Sudhir has been most happy to use K-wires, as discussed very well by Dr. Hemant Patel. And these are some of our concepts. So surgical tips for those who want to go into the nuances of harvesting the medial femoral condyle: you must identify the intermuscular septum and be anterior to it, more towards the vastus medialis. And then once you see the vastus medialis, you retract it anteriorly and then see the septum. If you go through the septum early, then you will enter the region of the popliteal artery and you will miss the vessels totally. And tracing the pedicle, seeing the vessels first over the condyle and then tracing them proximally into the muscles is easier. And so the condyle is exposed in the distal part of the incision and then lifted off, the vessels are lifted off. So if you wish, as I have shown, the transverse branch for the osteoarticular branch, so that if you need to take a little bit of cartilage or replace the proximal pole entirely. And you should be aware of this, the superior medial genicular artery which joins the descending genicular artery. Sometimes this is so if you see the descending genicular artery is not as big as you think it should be, then look for this vessel, and then you can take this vessel as the dominant vessel. So a high tourniquet helps you locate the vessels properly. So look out for abnormal vasculature. Normally you get a very long pedicle. So in fact, if you have a volar incision, you have to actually place the pedicle nicely so that so it does not kink, and then you can do an anastomosis a little higher up in the lower forearm to the radial artery. And we always use end-to-side anastomosis for the artery to artery and end-to-end for a smaller vein. We don't use the cephalic vein, but we find some smaller vein in the, or maybe one of the vena comitans of the radial artery as an end-to-end for the vein. We have had only one incidence of donor side complication, a hematoma in the leg. And otherwise, our patients have been most comfortable. In 3-4 days, we get them walking once we remove the drain. And within a week, the knee joint pain has gone and they're able to walk. This is mainly because we have used very small bone grafts, where the requirement for bone grafts in other areas is larger. We need to immobilize these patients for longer. And only other thing that you need to anticipate is the need for difficulty in skin closure. Then you can take a small island of skin. I thank Sudhir for all the work that we have done with this, and also Leena Jain, who's a plastic surgeon, and she's been with us for all the cases more than 20. I think now our number is 25, and she has also published this in the Indian Journal of Plastic Surgery. Thank you.
Thank you, Samir. Navin, if there are any questions.
Yes, few questions are there. I think there is no lectures now.
There's one last one by Randy.
You can finish and then we have a questions, I think.
We'll do that, okay.
Or 1 or 2 questions may get covered in that part.
Right. No, if there's any specific question for the...
yeah, meanwhile he's changing the screen, I can ask. Yeah.
Any specific one?
Specific question for Hemant is there. Do you leave the K-wires outside? If so, when it is removed? Or you bury inside? There's the 2 questions for Hemant.
K-wires are not left outside.
Not left
outside. Cut as flush as possible with the scaphoid.
Okay, now the particular question from Anil to Dr. Sudhir. Would you template pre-op with the opposite side scaphoid length or only on table by looking at the scapholunate ligament, the graft size and shaping you showed?
There's a lot written about the size of the graft. It's best to try and match it to the opposite side, the height of the scaphoid. Very difficult, again, to try and measure it because you need to get x-rays in the right position and things like that. And on table, you can't measure the size on an x-ray because you're now you're working with the C-arm. So there's lots of publications on this. There are publications that say you need to overstuff it. There are publications that talk about no bad effects from overstuffing it. There's also a publication which says you can understuff it and keep it in a little bit of flexion. So really very difficult, but the best thing is to stretch it out and look at the mid-carpal joint like I do and see that you've reduced the DC. So these are the 2 points that I keep in mind. So when you're looking at it from the lateral aspect without a pin inside the radio lunate and without a radiolunate pin, once the radiolunate pin is out, if you see that the DC is corrected, and if you see the mid-carpal joint smiling at you, that would be a good position for you to retain. Randy, any tips on that? You'll have to unmute yourself.
I have not done a single MFC or MFT.
No, not MFT. This is
yeah.
just...
No.
Yeah.
The question is regarding
Yes.
Sudhir's technique of making a graft, shaping a graft exactly.
Yes.
The Fis-Fernandez
Yes.
graft.
I do tend to overstuff it a little bit, but I think the key is to get the lunate tilt back, right? So your mid-carpal joint is reduced.
Okay. Dr. Dayanidhi is asking Hemant, indication of additional scaphocapitate K-wire.
You can use it if you feel that the fixation is not good. I have not used it in practice. You can use it. It has been described.
Yeah, Ram,
Ram wants to say something.
Yes,
Yeah.
if it is a very unstable fracture, like it's bent like that, when you do a joystick reduction and put single screw from the dorsal aspect, you might benefit from having a scaphocapitate wire. I've seen Dr. Joslake putting even a scaphocapitate accutract screw to hold it for 6 weeks and remove it. That has got a higher degree of scaphoid healing. But in my practice, I do a K-wire from the scaphoid to capitate in that period of time if it is a very highly displaced fracture.
Yeah, so I would like to add a couple of things. One is, once you've done your fixation, whether it's with a single K-wire as Hemant is doing now, or with a screw as in a comminuted fracture, when you put the wrist through its motion after your fixation, if you do find it's unstable, you would want to fix the scaphocapitate. This would also depend upon, if you remember the slide that I showed about where the DIC, the dorsal intercarpal ligament, is attached. If this fracture is distal to the DIC, then obviously you would probably require to fix the scaphocapitate if it's not stable enough.
Dr. Randy, the question is again from the Tahir Ansari. How is the experience with the bone graft substitute for a smaller gaps?
Bone graft substitute is good only in distal radius fractures where you got good healing and you got a contained cavity. Because in a scaphoid, you're kind of weak on the healing anyways. The healing is not on your side. It's not worth putting a bone substitute such as calcium phosphate. I would use bone graft. However, in a scaphoid cyst, not fracture, just a scaphoid cyst that's painful or symptomatic, I will curette and put a bone graft substitute arthroscopically, but I would not do it for a fracture scenario.
Okay, Dr. Kothadia is asking, excision of the scaphoid pole with filling defect with the tendon graft as a salvage procedure. What is the take?
I don't have much experience on it, but the fact is, if the overall carpus has not got a severe collapse and the fracture is distal waist, like Sudhir is talking about, distal to that dorsal radiocarpal, dorsal intercarpal ligament, then you can take out that piece. I don't know that you have to put anything in there. You simply excise that fragment of the scaphoid, and these patients do get pain relief. The advantage of that procedure, which I'll talk in my next talk about snack wrist, is that you don't lose anything, right? So if it falls apart, you can do a complete scaphoid excision and a four-corner fusion. So if you want to try it, you can do it. And if it doesn't work, you can convert it to a proximal row carpectomy or a four-corner fusion.
Okay, you can share the screen. Now the last question is there, but that is an opinion and that can be done at the last. Some section of the viewers are saying that we have completely demystified the scaphoid, but some section is asking that at the end, either Randy or Dr. Sudhir can summarize each situation so that it will be easy for them to digest everything.
I do have
one go.
I do have a slide to.
Okay. That's already prepared.
That's great. Thank you. So the last talk, just to talk about what happens when everything falls apart. And we know it's a common problem, which is why we've all been sitting here for almost 4 hours to talk about it. The biggest issue is 10 to 15% of these don't heal and they get wrist arthritis. That's what we and our patients are worried about. So here is a patient. This was when I was a fellow in Derby in England. So a long time ago. So see this patient, typical scenario, comes to emergency room, gets sent away saying nothing's wrong with you. So he shows up a year later, still hurting, and now we can start to see a fracture. In those days, it took a month to get a CT scan, so we should treat people on x-rays. So then we put a screw in. Now the only technique we knew then, and that was available then, was putting a Herbert screw, and everybody was putting it from this direction. But you can clearly see we've not got good stability, or we may have got reasonable stability, but there's been a bit of avascular necrosis. The fragment is collapsing, and then about 10 years later, the scaphoid is removed and the 4 bones are fused. So that's the scenario we want to avoid. Nowadays, tracking back, he would have had an MRI scan. MRI scan would have shown some bone marrow edema. We'd have got a CT scan. CT scan would say this is a proximal pole fracture. I would have told him, you're going to have a 30% chance of non-union. He would have signed up for surgery. I would have collected my cash and would have put a screw in. Everyone would have been a winner. Obviously, we know better now, 20 years later, right? So the problem is arthritis comes on late, and we still see a lot of young patients, sometimes with bilateral scaphoid non-union and advanced collapse of the wrist. So the problem is once they start getting the carpal collapse, they can start getting pain when they may have never had pain before. It's very similar to the slack wrist, but because it occurs with the scaphoid non-union, it's been given the acronym of snack wrist. Now the treatment, like slack wrist, varies with the stage of arthritis. So here's a patient. He's got early arthritis just here, scaphoid non-union. The lunate is only slightly dorsally tilted, so it doesn't look too bad at this point. So he's an early case of non-union. So in this case, all we have to do is get this scaphoid fracture fixed, take away the styloid, and then we have achieved a situation where the pain is relieved and everybody's happy. If that fails, then we can consider fusing the scaphoid to the capitate and lunate as a limited fusion on the radial side. So here is that patient. We've got a screw in there. The bone has healed with iliac bone graft that we have placed in there and radial styloidectomy, and that patient is satisfied. Now, sometimes we will do a scaphocapitate fusion. So if they have a lot of arthritis over here, we'll curate it, put bone graft, and get fusion in this area. And when I worked in St. Louis with Dr. Mansky, that used to be his favorite operation for when a scaphoid non-union failed and the patient was starting to get some arthritis at the mid-carpal joint. It's not considered very popular now because the loss of motion can be quite substantial because you completely lock down that mid-carpal joint. When you look at the only series that's out there talking about scaphocapitate fusion, you can see it's an old series. So currently not a very popular operation, but the reason being these patients continue to have pain. And the problem is this radioscaphoid joint is not conducive to much movement. So if you lock this joint into place, patients get incomplete pain relief because of that. So we've now kind of moved away from doing a scaphocapitate fusion. And the only time I will do this fusion now is more for Kienbock's disease rather than for scaphoid non-union. So in this kind of a scenario where you've got a proximal pole non-union and you've started to get arthritis along that radioscaphoid joint, what we call a SNAC 2, you've got a good mid-carpal joint. So now you still do have an option to do a proximal row carpectomy. Or you can still do a four-corner fusion, but you might generally wait for a more severe arthritis to do that. Now, if you're going to do a proximal row carpectomy, the key is this will be a dorsal approach. You'll do a capsulotomy, and you have to check that the capitate surface is good enough. And then all you have to do is take out all the carpal bones. Make sure you preserve the volar capsule. So here you can see the radioscaphocapitate ligament and the long radiolunate ligament intact. The capitate surface should be pristine. If it's not pristine, you can instead do a four-corner fusion. So often I will consent my patient for both and do a four-corner fusion if the capitate is not as good as it looks like it should be. And this is what it kind of looks like. Patients get a pretty good range of motion. The beauty of this operation, you don't have to wait for any healing. After 3 weeks of a cast, patient can start moving their wrist. There is no healing involved. Now, in these cases, when you have a SNAC 3 and you start to get arthritis of the capitate, your only option left there is to do a four-corner fusion, where you'll take out the scaphoid and fuse the remaining carpal bones together. So here is that patient. He's got some mid-carpal arthritis already starting. So what we are doing is a dorsal approach. The key here is to correct the DC deformity, otherwise the fusion mass will impinge on the dorsal radius and they won't get back adequate wrist dorsiflexion. So it's important to flex the wrist fully. When you flex the wrist fully, the lunate will come up, pin the lunate, and then you can continue with the fusion. So here is the intraoperative picture. I've got a joystick in the lunate. I've flexed the wrist completely so that I've got the lunate now coming up. Then we've got a pin into the ulnar half, radial half of the lunate. Now we can prepare the capitate and fuse it with the lunate in a better position. So by bringing the wrist into maximum palmar flexion, the lunate dorsiflexion is now corrected. It's pinned to the radius temporarily till we finish the operation. Now in this case, I've used a circular plate. So you put in the reamer gives you a nice exposure. Then you can excise the articular surfaces and you can place the plate in there. Important thing is to make sure the plate is fully recessed. So that's what it looks like when it's fused with the lunate now in a neutral tilt. They get back a reasonable range of motion. So on an average, they get 30 degrees palmar flexion, dorsiflexion. So they lose about 50% of the range of motion. Now, if they've got arthritis everywhere, including the lunate, like in this patient with a proximal pole who's resorbed, you can see they've got arthritis and a big osteophyte dorsally. their best option here, because it's a stage 4 arthritis, is to get a total wrist fusion where you put a plate on that. Now, what about doing just a distal scaphoid excision? So if you have a scaphoid non-union that's quite distal, so most of this scaphoid is preserved, you can try this. The problem is there's only a few case series. So when you look at this meta-analysis done by Mayfield 2 years ago, what they found was most studies are small, 6 to 10 patients or about 11 patients on an average. But these patients have had multiple surgeries and about an 11-year average non-union. What they found was the range of motion is excellent. Look at the range of motion, almost equal to the other side. Radial ulnar deviation about 50%, and grip strength, they get an amazing recovery of the grip strength compared to the preoperative. So the range of motion, grip strength improves a lot, as does the dash score, improves a lot from pre-op. However, you still have pain in about 20% with strenuous activity. So what they found was you get about 90% satisfaction, but some amount of pain remains. The good news with this operation in my hands is if it doesn't work, I can go back and do a proximal row carpectomy. So now you will ask, what about wrist denervation? I think most of us do a partial denervation as part of the operation whenever we're doing a 4-corner fusion or proximal row carpectomy. So doing a partial wrist denervation is probably a good option when you're doing it, and it's simply a small incision where you do your proximal posterior intraosseous neurectomy. You can go through the intraosseous membrane and do the anterior intraosseous nerve excision. So now to compare proximal row carpectomy versus scaphocapitate fusion versus 4-corner fusion, this kind of gives you an idea where your range of motion, flexion extension, if you do a proximal row carpectomy, you have 70% motion. If you do a 4-corner fusion, you get 50% range of motion. So just to give you an idea, PRC probably gives you better motion. If you look at this study from Joe Dice's group, what they found was this is your normal wrist range of motion. Proximal row carpectomy gives you a better range of motion. The wrist moves in the more normal arc. A 4-corner fusion moves in a less normal arc. So in terms of keeping your normal arc of motion, although it's reduced, PRC is probably better than 4-corner. So it's more natural. However, when you look at proximal row carpectomy and a systematic review, what they found was, this was from the Mayo Clinic, and they looked at all literature. What they found was if your age is under 35 and you're doing manual labor, PRC is less reliable, higher failure rate. So to summarize, what are you going to do with your patient? You've done your scaphoid operation. They've had multiple procedures. Well, you can consider some form of partial fusion. If the patient is over 35, PRC gives you a good result. You'll get about 70% of motion, 80% of grip, and 80% pain relief. However, in a younger patient under 35 years of age, manual laborer, a 4-corner fusion will give you a more reliable result. Some pain may remain. You can add a wrist denervation in these operations, or you can do it on its own. You can do a distal scaphoid excision. Again, if it fails, you can convert to a PRC or a 4-corner fusion. However, if you have a patient who says, I want the one operation, I want to get on with my life, I'm looking for pain relief, then probably I would tell them, have a total wrist fusion. With a plating technique, you'll get a 95% union rate and a 90% pain relief rate. So that would be my option for the patient who wants only the one operation. Thank you, Sudhir.
Wonderful. Wonderful.
Thank you. Thank you. There is one question follow-up from Dr. Anil, again, hand surgeon, to Dr. Andy. Can lunocapitate fusion be good enough instead of 4-corner fusion after scaphoidectomy?
For sure. I think Greg Bain has shown that if you take out the scaphoid and you take out the triquetrum, you will get a better arc of radial ulnar deviation. However, you reduce your fusion mass. So you have to keep that in mind. So technically you have to be more careful at the way you do your fusion, but it may give you a better range of motion, but your fusion rate may drop down because your fusion mass is much smaller. So you have to keep that in mind.
Okay. Now Sudhir is going to say some summary, I think. And Randy, what you are using? You are using Surface or it is an iPad with a pencil?
I am using HP.
Okay. HP. Hello, you are muted. Oh. Are you getting our voice?
Yes.
Okay.
My cordless headphones battery has died off.
So it's
an indication.
It's time to go.
It's time to go. Okay, so let us summarize. And
It's a quick summary. Okay, so we've learned that we need to first identify the ones that are undisplaced or displaced less than 2 millimeters and see that they're not opened out. And if it's an acute fracture, you can conserve because most of them are going to heal, but we need to keep a watch and decide at 4 to 6 weeks and pick out those truant ones that are not following what we expect. That means they're not healing well. And in those, we need to then think in terms of fixing them. We would think in terms of fixing these directly on the first time we see them, even if they're undisplaced, in professionals who require that, in some sports persons who may want to go back to, it probably doesn't influence too much the healing time. But if it is like the ones where it's not the dominant hand, maybe they can go back to playing as well. If there is travel in the offing, so if someone's going off for studies or something like that, there are social indications where you might think in terms of fixing. And if someone looks at those x-rays, they say, why did he fix this? It's because there was some problem that someone had to move away to, you have students, a large number of students before they go off to America, they have these fractures and you say, this is going to heal, but what if it doesn't heal? And he's in America, he doesn't have his insurance. So that's the kind of indication that I would add. And of course, in polytrauma, like we discussed, I would think in terms of fixing these directly. When you're thinking in terms of fixing any of these, you need to think of two methods. One is percutaneous or open, depending upon your skill, depending upon your experience. And if it is displaced, I would rather do it open than fiddle around with joysticks if I'm not very good at it. You need to understand that the fixation needs to follow all the principles that we discussed today. Let's now look at the displaced fractures. We need to reduce and fix them, and we can choose either wires, screws, or plates. Each has its indication. Each requires certain principles to be followed. And if we follow those principles, we can expect more than 90% success in any of these techniques. When we're using wires, we can also think in terms of whether we want to do it percutaneous or open. And finally, when you're dealing with non-union, you need to look at two things and decide what type of treatment you're going to give. So you need to look at collapse and avascularity. So you need an MRI and you need a good CT scan. So once you've got these, you can decide. So if there's no collapse, if there's no avascularity, you can use cancellous grafts with a compression screw. If there is collapse and there is no avascularity, that means you're expecting good bone to heal well. You use, and if it's usually in the waist, you can use the Fisk-Fernandez iliac crest wedge graft, and that should give you more than 89% success with a screw or with K-wires. If there is no collapse, but there is avascularity, you can use the distal radius vascularized graft, either from the volar side or the dorsal side. The volar side is the Matula graft, or the dorsal side could be the 1,2 ICSRA, or from using the capsule and a portion of the distal radius attached to a nice wide pedicle. So that's a simpler graft to get. It's not based on very thin or very tiny vessels. It's easier, and if you just use a pair of loops, you would probably be able to do that. And finally, if there is collapse and there is avascularity, And if it's a failed of any of the above procedures, then your last recourse before you go on to salvage operations would be a femoral condyle microvascular graft. And I think that about puts everything into a nutshell and tells us what we could do when we're dealing with scaphoid fractures in the acute and in the non-union phase. I wouldn't go into details of the snack wrist, which Randy has just spoken pretty clearly right at the end of this talk. Thank you very much for all of you having spent 4 hours and 9 minutes with us.
Yes, yes, it is the longest one. It is the longest one. And let me thank all the viewers and all the faculties. Just all the faculties have given a best in this webinar. And also, at last, we have to thank you, INTAS people, Calenta Max, Hyphenec, and Terrifrec. They have supported educational grant to Gujarat Orthopedic Association. Thank you all delegates and all the faculties.
Thank you.
Any questions are remaining, we'll pass on to the faculty and we'll get email to the questioner. That is a possibility we are exploring. And we are very much thankful to Dr. Andy for staying 4 hours, exhausting your mic and giving extension to further webinars when we need. You said in an email, and probably I answered your questions in the email. I think you're satisfied with the answers. Okay. We cannot hear because your mic has gone. You're muted. You're muted. You're muted. Now you can speak, sir.
Need to
Faculty was a great idea.
Yeah. Thank you. Thank you, sir. Thank you, sir.
Thank you very much.
Thank you. So I'm ending the meeting now and I'm stopping the streaming. You can have a